There are times when you might feel aimless. You can't see the places where you belong. But you will find that there is a purpose. It's been there within you all along.
And when you're near it, you can almost hear it.
It's like a symphony. Just keep listening, and pretty soon you'll start to figure out your part. Everyone plays a piece, and there are melodies. Each one of us. Oh, it's glorious. You will know how to let it ring out as you discover who you are. Others around you start to wake up to the sounds that are in their hearts.
It's so amazing what we're all creating.
It's like a symphony. Just keep listening, and pretty soon you'll start to figure out your part. Everyone plays a piece, and there are melodies. Each one of us. Oh, it's glorious. Glorious, glorious, glorious. That you feel the notes build higher.
Huh?
It's like a symphony. Just keep listening, and pretty soon you'll start to figure out your part. Everyone plays a piece, and there are melodies. Each one of us. Oh, it's glorious.
Tayo na yun. Gumanito lang yun, no?
Hi, good morning, everyone. And sige po, so before we begin, let me introduce myself po. I am Mark Adlawan. So I'll be discussing po your ACLS together with your ECG and pharmacology. I'm all the way from Davao City pa po. I've been with, ano na ba? Ilang years na ba with WePam po? Siguro mga 5 years to 6 years na po, guys. Ayan, sige, so let's begin na po. Now, we are done na po. Basically, tapos na po kayo ng BLS together with your instructor. So I was tasked po to give lecture sa ating ACLS together with the mega code po na mamayang hapon. Ayan, so before I begin, ayan, magre-recap lang po muna tayo regarding the acute coronary syndrome by simply having the video na po coming from AHA or the American Heart Association. Volume up muna tayo.
Hirap mag-PDF, nakagawa. Forme, upo.
Leticia,
Hey, Jack, what's up?
happy Monday. When you finish with this, I need you to clear off the end cap down there. I got a whole bunch of promotional items coming in. We got to put them somewhere.
Okay, sounds good.
Oh,
You all right, Jack?
yeah. Yeah, I'm fine. I think it's that stuff that everybody's got going around.
Okay.
Acute coronary syndromes, or ACS, may suddenly strike men and women, often after years of asymptomatic coronary atherosclerosis and plaque formation. As plaque forms within the coronary arteries, several clinical syndromes may also develop, with varying degrees of coronary artery occlusion. Two of these syndromes are non-ST segment elevation acute coronary syndromes, or NSTEACS, and ST segment elevation myocardial infarction, or STEMI. STEMI is generally considered to be more serious and usually develops after a ruptured plaque or an erosion results in an acute blood clot that significantly or completely occludes a coronary artery. Either of these syndromes can, unfortunately, manifest as sudden cardiac arrest and death. It's estimated that half of the deaths from these syndromes occur outside the hospital, making early recognition and rapid response essential. The best outcomes from ACS occur in communities where programs with strong public education, PAD programs, and STEMI systems of care exist. Watch how emergency medical services and hospital personnel use the STEMI chain of survival to provide a system of care that recognizes and rapidly treats the underlying causes of ACS.
What's going on?
I think Jack's having a heart attack. I'm gonna call 911. You get the AED and first aid kit.
Okay.
911, what is your emergency?
I think my manager's having a heart attack.
I see you're located at 459 Commerce Avenue, is that correct?
Yes.
Where is the patient?
He's right here. He was wobbly on his feet, so we sat him down in the aisle. He's having chest pains and his left arm hurts.
Is he awake? Can you talk to him?
Yes, he's awake and able to talk.
I'm going to dispatch paramedics to your location. Stay on the line with me, okay? Don't hang up. I'll have a few more questions to ask you.
Okay.
The first step in the ACS algorithm involves the patient, bystanders, and medical personnel recognizing the warning signs of cardiac ischemia.
We all had basic first aid training and CPR training about 6 months ago. And when Jack said his chest was hurting and his left arm was hurting, that's when the alarm bells went off for me.
Our system uses priority dispatching protocols, which help identify the problem and determine what type of response to send. What the caller described fit the protocol for ACS, which required a high priority EMS response.
While waiting for EMS to arrive, dispatchers may advise patients to chew 160 to 325 milligrams of non-enteric coated aspirin. This recommendation should be in line with approved medical protocols, and only if the patient has no history of true aspirin allergy or gastrointestinal bleeding.
Okay, paramedics are on their way. Stay on the line with me until they arrive. Do you have a first aid kit with you?
Yes, and I have our AED too.
Great. Is the patient still conscious?
Yes, he is.
Okay, then we won't need to use the AED right now. Ask if he has an aspirin allergy or any recent bleeding from his stomach.
Jack, do you have an allergy to aspirin?
No.
Have you had any bleeding in your stomach recently?
No, I don't think so. No.
No to both questions.
Look in the first aid kit. If it has aspirin, have him chew 2 to 4 baby aspirins or 1 adult aspirin while you wait for the paramedics to arrive.
That brings us to the next step in the ACS algorithm: assessment, care, and hospital preparation.
He's been having chest pains for about 10 minutes. The night an adult aspirin to chew.
Sir, how you feeling?
Not so good. It's my chest. I feel like somebody's squeezing it.
Okay. Well, we're gonna help you out, reduce that pain. I'm gonna get a 12 lead. Go ahead and get his blood pressure and put him on a pulse ox.
When we arrive on scene, the clock is ticking. I know I've got to assess, but if he doesn't need immediate resuscitation, my highest priority is to obtain a 12-lead ECG, manage the symptoms, initiate transport as soon as possible. Every minute matters. The longer it takes to get to the hospital, the poorer the outcome for the patient. In fact, half the people who die from ACS are dead before they even reach the hospital. So I follow the ACS algorithm closely just to make sure that doesn't happen.
Administer supplementary oxygen if the patient's oxygen saturation value is less than 90%. Give aspirin if the patient hasn't taken any yet and there are no contraindications. It's critical that out-of-hospital healthcare providers obtain a 12-lead electrocardiogram.
Looks like a STEMI.
This early ECG helps classify patients suspected of having an ACS into 2 groups based on ST segment deviation before they reach the hospital. It's preferred that patients with ST segment elevation be driven, if feasible, to a hospital that performs primary PCI. This initial ECG speeds the patient's diagnosis and shortens the time to reperfusion.
Recognizing ST segment elevation on a 12-lead ECG takes training and practice because different thresholds exist for patients depending on their age and gender.
If a STEMI is suspected, EMS should notify the hospital or transmit the ECG for interpretation.
The patient had ongoing symptoms of ischemia, So we administered nitroglycerin sprays every 3 to 5 minutes for a total of 2 doses. 3's the max. We monitored the patient's blood pressure in between each dose.
Before giving nitrates in any form, make sure there are no contraindications, such as severe bradycardia, tachycardia, or hypotension. Also, confirm that the patient hasn't taken any phosphodiesterase inhibitors for erectile dysfunction in the past 24 to 48 hours. Patients with inferior wall STEMI on their 12-lead ECG can often have right ventricular involvement. This can be confirmed by a right-sided 12-lead. If RV infarction is present or suspected, nitrates in all forms are contraindicated. Clinically, it may be suspected in patients with hypotension, clear lungs, and elevated JVD. If the patient receives nitroglycerin but does not experience pain relief, healthcare providers can consider giving analgesics such as morphine while monitoring the patient's blood pressure and respiratory rate. Use morphine with caution for patients with unstable angina.
County Medical, this is Rescue 1. We've got a STEMI alert. 46-year-old male, chest discomfort started half an hour ago. Current vital signs are BP 104/78 with a heart rate of 96. Pulse ox 95%. He's chewed 325 milligrams of aspirin and received 2 rounds of nitroglycerin sprays, but still says he has chest discomfort. 12 lead shows ST segment elevation of 3 to 4 millimeters in leads V1 through V4. ETA to your facility is 10 minutes.
Rescue 1, we received your 12 lead and your initial report. We'll activate our heart alert system, contact the cardiologist and the cardiac cath team. We'll see you guys in a few minutes.
Let's get ready.
Getting this advance notice really helps us speed treatment of these patients, increasing their chance of survival. We can have the cath lab prepped and ready by the time the patient hits the doors of the ED.
The American Heart Association recommends that EMS personnel transport patients who have a STEMI to the closest appropriate facility that provides reperfusion without delay.
Hi, sir. I'm Dr. Taylor. We're going to take great care of you today.
After we last talked, his pain is down to 2 out of 10. Otherwise, he's stable.
Let's get into that.
Right. Studies show that ED evaluations are responsible for as much as 33% of the total time from symptom onset to treatment. We try to reduce delays by having everything ready when the medics arrive. After seeing the 12 lead that the medics had sent, I immediately activated a PCI team and alerted the cardiologist.
When the patient arrives at the ED, we move to the next step in the ACS algorithm. Reperfusion goals for STEMI patients include PCI within 120 minutes after the first medical contact, or fibrinolytics within 30 minutes from ED arrival. The appropriate therapy is defined by patient and center criteria.
Within the first 10 minutes after arrival, the ED staff should provide an immediate assessment of the patient. That includes taking vital signs, getting a brief, targeted medical history, completing a fibrinolytic checklist, and obtaining blood studies. If the early ECG shows no signs of ST segment elevation, then a repeat ECG in the ED is warranted. Staff should also get a chest x-ray within the first 30 minutes after arrival. Draw the STEMI panel. I've activated the STEMI pager and get him to the cath lab as soon as they're ready.
Adjunctive treatments include unfractionated or low molecular weight heparin, bivalirudin, P2Y12 inhibitors, IV nitroglycerin, beta blockers, and glycoprotein 2B3A inhibitors.
Hi, I'm Dr. Taylor.
Hi, how is he? Did he have a heart attack?
I'm afraid so, but his vitals are improving, and we're moving him to the cath lab. This is going to allow us to see inside his heart and his arteries and treat it as well. Dr. Abrams is an excellent cardiologist, and he'll be helping you through the next steps. You'll be in good hands with him, okay?
Thank you.
This patient presented with ST segment elevation of 3 to 4 millimeters in leads V1 through V4. Now, this suggests that his LAD artery is occluded. Immediately opening up the artery with PCI and restoring normal blood flow is my primary goal.
The final link in the STEMI chain of survival is treatment. The preferred reperfusion strategy for STEMI patients is PCI, when patients meet the 120-minute window from first medical contact or 90-minute window from ED arrival, to balloon inflation in the catheterization lab.
Hi, Mr. Brennan, I'm Dr. Abrams, your cardiologist. How are you feeling?
Not so good.
Well, hopefully you'll be feeling a lot better soon. I just want to talk to you a little bit about what's going on. I've reviewed your ECG, and it appears you have a blockage in one of the arteries to your heart. Now, to open the artery, we need to perform a procedure called PCI that'll help reestablish blood flow to your heart. Basically, we insert a catheter into the artery with the blockage and inflate a balloon to widen the blocked area. We then place a stent to keep the artery open. And the sooner we can do this procedure, the less damage may be done to your heart. Okay?
Okay. I understand. I'm ready.
All right. Well, let's see what we can do to help you get better, okay? All right.
PCI opens the blocked artery with a tiny balloon. Then a stent, or metal scaffold, is inserted to maintain blood flow to the heart. When choosing between this reperfusion strategy and fibrinolytic therapy, hospital personnel must consider a number of factors. Studies show that treatment delays increase mortality in both groups, regardless of the reperfusion strategy chosen, but were more pronounced among those patients receiving fibrinolytic drugs. In these cases, the more time that goes by, the more heart muscle is lost. The better EMS systems and medical centers work together, and the faster they can deliver treatment, the more heart muscle and patients can be saved.
We had a great outcome with that patient, but we wouldn't have if every link in the chain hadn't been working cohesively.
All the pieces fit together perfectly, and it all began with a call from his coworker. The dispatcher assisted in the administration of aspirin prior to our arrival. We were able to get to him in time, identify a STEMI, and move him quickly to a hospital where they were ready to do PCI. He's back at work today because of it.
Ayan, before we start, okay lang po bang paano muna guys? Pa-on muna ng mga cameras po natin para at least makita ko ang mga students po natin, ng mga trainees po. And I'd like to recognize also na our doctors, and nurses, midwives, and welcome to WePump Training Center. Ayun, I can see familiar faces po. All right, let's begin. So for ACLS guys, ang kailangan na backup knowledge po natin dito, you need to have a strong foundation with your BLS or the basic life support. Now I'm pretty sure na na-discuss na po ang HEPA filter po sa atin. The HEPA filter guys na is the BLS or let's say the airway management to battle COVID. Diba ito yung ginagamit natin, ina-attach po natin sa ating BVM or the HEPA filter po. Na? Ayan, para kasi protected po tayo 99.97% no, against the COVID virus. For sure, sa Bicol, hindi pa nakapasok si Delta variant. But in Davao City, kakapasok lang po ng Delta variant last July, I think July 15. And then kahapon lang talaga nila na brinodcast na nakapasok na talaga si Delta. And then yung Delta po na variant, yung BFP pa talaga ang nag-carry nun. Tapos si BFP guys, meron siyang 16 na katao na na halubilo. So possible po yung 16 na yon if ever kung hindi po vaccinated or fully, then ma-acquire talaga nila. Pero if ever kasi 'di ba, if you're fully vaccinated, then at least 50% lang na hindi ganun ka grabe talaga na yung severity po ng ng COVID po natin. Okay, so for your ACLS naman, we will be following the COVID protocols also, in which we need to limit personnel. The same din po ng ating BLS, 'di ba na-emphasize po. We limit personnel, we should don PPEs dapat na you should never start with your BLS or your high quality chest compression if ever kung ang client po natin ay COVID positive and then mag-start ka ng walang N95 mask. You need to wear your mask dapat. Do not focus on the ventilation na if ever kung mag-isa ka lang. Pero kung may kasama ka, yes, you can make use of the HEPA filter. Yun yung pinaka-importante. Okay po? Ayan, so let's begin now. As part of the introduction, guys, now we need to always correlate our let's say topics sa ating COVID. No? Kasi yun yung pinaka-importante. Ano pang saysay ng training na to kung hindi naman po natin siya i-correlate doon. So may mga moments na, ayan, it should be ACLS and COVID. No? BLS dapat and COVID. Now, ano bang pinagkaiba ni ACLS at saka ni BLS? A quick review lang. When we say BLS, guys, the patient here is unconscious. So we have an unconscious, patient. And that's for the BLS. Now, for the ACLS naman po, we have a conscious Ayan, conscious. Okay, patient here. So, upon arriving at the scene po, the patient is unconscious, then we need to perform BLS. Pero pag, okay, let's say sa ER, arriving na ang patient natin, complaining of chest pain, tapos cold clammy diaphoretic patient, tapos nag-introduce ka ng self mo, good morning, Mrs. Fernandez, I am Mark Adlawan, your most responsible nurse. How are you feeling today? Ayan. So pag sumagot ang client mo, then meaning to say, yan, conscious si client, so you are performing the ACLS survey. And then guys, to complete na the package okay, of the said training, we need to have our PCAC. If you're familiar with your PCAC, this means post-cardiac arrest care. When we say post-cardiac arrest care, now, si patient kasi posibleng magulay right after the said arrest. Now, if nagulay ang client po natin, then we need to prevent further pa na damage sa brain ng client. So usually, now we can perform the therapeutic, the targeted temperature management or the TTM, and that will reduce kasi the oxygen demand from the brain. That will be the focus po sa ating PCAC. So once again, ulitin ko, BLS usually happens on a pre-hospital setting. It's outside the hospital. When we say ACLS, this means in an intra-hospital setting, inside the hospital. Of course, PCAC din, malamang inside the hospital din yan. Intra din to eh. Especially if you want to refer the client na po sa ICU po natin. Okay po? Ayan, sige, let's begin now. In discussing ACLS kasi, now we need to go back sa anatomy review. But my focus now will be yung mga natin, yung mga conduction system po natin. Sino yung mga primary pacemaker doon? Sino yung mga secondary pacemaker po natin? Up to the Purkinje fiber. Okay po? Ayan, for a while. Pakita ko lang ha. For a while. Okay, so we have the conduction system of the heart. Balikan ko lang yung mga polarization po natin. For the conduction system of the heart, we have the sinoatrial node up to your Purkinje fiber. Now, the question is, sir, paano ba i-discuss yan? So I have my own mnemonic known as the mnemonic sublurp. Okay? So we have sublurp. Na matanong ko lang, sino po yung mga natin, mga doctors po natin dito? Pa-heart sign na lang po, pa-heart reaction na lang sa ating mga doctors. Meron po ba? Sa pagkakalam ko si Doc Melchor ay doktor po. Sino pa? Aside kay Doc Melchor, meron pa po bang mga doctors? Pa-heart sign din po, pa-heart reaction guys ng ating mga lovely nurses po. Meron po ba? Doctors po ba lahat? Matanong ko lang. Pwede pong mag-unmute ng mic guys ha. Pwede pong mag-unmute. Na walang problema sa akin yun. Especially when I ask questions po, pwede pong mag-unmute. Now, I'd like to hear it from Dr. Melchor. Hi, Doc. Pwede bang mag-unmute si Doc Melchor?
Hello po.
Hi, Doc. Doc, saan ka nag-work ngayon, Doc?
Sa Naga City.
Sa Naga. Ayan. Welcome to WePump, Doc. Ayan. Sino pa dito ang mga doctors po? Sino pa dito ang mga doctors? Si Miss Karen de maunahan ba? Doctor po or nurse? Pwede pong mag-unmute ha. Hello, Ma'am Karen.
Nurse po, sir.
Nurse.
Hello
Hi,
po.
Ma'am Karen.
Nurse po.
Saan ka nag-work, ma'am?
So na po, wala po. Nag-apply pa po. Galing po akong abroad, kakauwi lang.
Nice.
Nag-update lang po for updating.
Nice.
Ng mga trainings.
Nice. Welcome to WePump, ma'am. And I'd like to ask Miss Manyo. Miss Manyo, pwede pong mag-unmute ha?
Yes po. Hello po.
Hello, Miss Manyo. Nurse po, ma'am, or doctor po?
Nurse po.
Nurse. Saang nurse, ma'am? Saan ka nag-work ngayon, ma'am?
Sa Catanduanes po.
Sa Catanduanes. Na-miss ko ang Catanduanes. Dati kasi guys, na last year, ako kasi yung parang primary na lecturer po, instructor ng WePump. So we traveled Bicol, as in like the whole Bicol talaga province po ayan, na-miss ko tuloy Ayan. How about Mr. Bakuli? Nurse po or Dr. Mr. Rondel?
Nurse po, sir.
Nurse. Taga saan ka nag-work, sir, ngayon?
Dito po sa sir, sa PNP po, dito sa Quezon City po.
Ay, nice. Police pala si sir. Hi,
Opo,
sir.
nurse medic po, sir.
Ay, nice, nice. Sige, sir, relax ka lang dyan, sir, ha? Nasa ambulance ka ba or nasa sasakyan mo?
Nasa ambulance po ako, sir.
Nice. Sige, sir, relax ka lang dyan. Ayan,
Sir.
how about, welcome to WePump. How about Mr. Paul Respicio? Doctor po ba, sir, or nurse?
Medtech.
Medtech. Welcome to WePump po. Ayan, welcome to WePump. Ayan, how about Papa P's Restaurant? O, di ba, ang social ng ano natin, ng pangalan. May Papa P's Restaurant pa talaga eh, no? Sir, nurse po ba, sir, or doctor?
Ano po, sir? Nurse po, nurse.
Nurse. Taga saan ka, sir?
Catanduanes po, sir.
Catanduanes. Na-miss ko yung Catanduanes. Na-miss ko din yung kabit ko dyan, Chos. Regards na lang sa kabit ko, ha. Andyan po siya sa Catanduanes. Architect po siya ngayon. Chos. Kaya gusto ko nang gumala, no? Especially Bicol, no? Bicol kasi sobrang grabe, ang dami kong memory sa Bicol. Nandiyan din kasi yung ex ko na nasa Bicol po. Ayan, so we have here the sublurp, guys. Now, when we say sublurp, na letter S for SA node. Ayan, sulat lang po natin. So we have your SA node, letter A for AV node. Next, we have the bundle of His. Ayan, bundle of His. We have the left and right bundle branches. And then we have the Purkinje fiber. Now, listen carefully. When we say SA node po, this means your sinoatrial node. This happens to be as the primary pacemaker. If this is the primary pacemaker po, expect na ang firing rate po natin will be 60 to 100. Meaning to say that 60 to 100, guys, is the normal heartbeat of a normal patient. Diba? Ano nga yung term natin pag less than 60? It's bradycardia. Pag greater than 100 naman po, it's tachycardia. Okay? Now, for AV node naman po, or the atrioventricular node, this is the secondary pacemaker. Pag sinabi natin primary and secondary, pag primary po, siya talagang nag-action first. Primary Pero if there will be a problem with your SA node, then si AV node na lang magfa-function. However, pag nag-function po ang AV node po natin, magiging 40 to 60 na lang po ang firing rate natin. Then this is the start of your bradycardia. Kaya 'di ba mapapansin natin yung mga first degree AV block, second degree AV block, third degree AV block, na expected po guys na na ang nagulat ako sa picture ni Papa P. Nagulat ako sa picture mo, sir. 40 to 60 po. Ayan, so we have the AV node, guys, ha. So pag 40 to 60 ka, meaning below, okay, 60 na po, bradycardic patient na po yan. So the same pa rin ang flow natin from the bundle of His left and right bundle branches. And we have the Purkinje fiber. Take note, the firing rate of the Purkinje fiber will be only 20 to 40 na lang po. So meaning to say, kung may bradycardia ka, may severe bradycardia ka with the Purkinje fiber. So again, ang tawag dito, guys, these are the conduction system of the heart. Now, para ma-achieve natin ang 60 to 100, alagaan po ang heart natin. Pero minsan kasi, kahit gaano mo paalagaan yan, na kung masasaktan talaga yan na hugot, sir. Ayan. So balikan po natin. Aside from discussing the conduction system po, let me share to you regarding the polarization. When we say polarization po, this means the ready state, okay, of our heart, di ba? So pag sinabi natin ready state, pwede kasing maging depolarization yan. At saka pwedeng maging repolarization. When we say ayan, no, you are, okay, what, no? Siyempre may ginagawa ka dito. Meaning to say contraction state ng heart natin yan, pag depolarization. Pero pag repolarization, meaning relaxation. So magre-relax ang heart natin. So pag sinabi kong depolarization, that means contraction. Ayan, we need to work, 'di ba? We need to work, no? Depolarization 'yon. Pero if we want to relax po, that's where the repolarization. Ayan, so mag-chill na po yung heart po natin. Relax lang siya. So we have here the word depolarization. Guys, when we say depolarization, this means contraction rather. Contraction or what we call as the stimulation. 'Di ba pag tatakbo tayo, we tend to contract. We tend to work our butt offs po, no? Stimulated po tayo. Pero pag sinabi po nating repolarization, that means the recovery state of our body, of our heart, or basically the recovery state or the relaxation state po. So we have the word repolarization or relaxation. Now, sir, paano ba mag-analyze ng ECG? Ganito yan. How are we going to analyze ECG now? Sir, number one, you tell me the heart rate first. To be followed by, you tell me the rhythm. Next, you tell me the P wave. Kamusta ba ang P wave natin, sir? Next, you tell me regarding the QRS complex of our patient. Now, quick review lang ha. Sir, paano ba mag-analyze ng tinatawag na ECG? So, ipapakita ko ang DART simulator. Guys, medyo maingay ang DART simulator, so you adjust your volume now. Tone down muna tayo. Okay, so how are we going to analyze ECG? So we have 5 steps po. Number one, you tell me the heart rate. So the heart rate is 79. Sorry, 79. 70. The heart rate is 70. The rhythm is regular. I can see P waves. They are clear and upright, followed by QRS, which is narrowed and normal in nature. So therefore, the patient here is experiencing a normal sinus rhythm. Next, paano ba let's say, pakita tayo ng abnormal. Natawa ako sa pakita tayo ng abnormal. Pakita natin yung mga X natin na abnormal. So we have the 100. The heart rate is 176. The rhythm is regular. I can see P waves, but they are unclear and they are buried. And I can see QRS, which is narrowed in nature. So therefore, the patient here is experiencing atrial tachycardia, or the SVT, or the supraventricular tachycardia, or the narrowed complex tachycardia. Now, another abnormal. Pakita ko si another abnormal. So the patient's heart rate is 0. The rhythm is chaotic in nature. There's no P wave, there's no QRS. So therefore, the patient here is experiencing a sudden cardiac death experience known as the ventricular fibrillation. Now, I have a question. If ever kung may VFib po na nakikita sa screen, ano ang ginagawa po natin? Is it automatic defibrillation or compression muna? Ayan, iba-iba po ang sagot. Pero ang pinakatamang sagot is that you need to start with your compression first before defibrillation. Kasi it takes time pa po para mag-defibrillate. 'Di ba? Magcha-charge ka pa, maglalagay ka pa ng conducting gel. Why not mag-start ka na automatic ng tinatawag na compression? Guys, once you compress, it should always be a high quality chest compression. Hindi lang yung compression lang. Okay po? Kasi ganito yan. There should be a combination kasi. An early compression plus your early defibrillation, especially for those who are shockable rhythm, then maganda po ang prognosis ng client natin. Kasi pag puro ka lang din, compression, without even defibrillating the client, tas shockable, then useless lang po ang efforts natin. Okay? Ayan. At hindi rin tama na unahin mo ang defibrillation. Guys, it takes time. Sayang po, di ba? Ipalikan mo yung BLS mo. Ang sabi kasi doon, there should be no, 'di ba, interruption to no, 'di ba, no interruption for more than 10 seconds. Kasi pag nagkaroon na ng interruption yan, pangit na po ang prognosis, pangit na ang compression fraction ratio ni patient. All right? Ayan, sige, balikan po natin. Introduction pa lang po tayo, guys. Wala pa po tayo sa actual na lecture po. Now, sir, paano ba natin malaman ng heart rate? Himay-himayin natin ha. Now, I want you to memorize something po. Yeah, you memorize this. 300, 150, 100, 75, 60, 50, 40, 30, 20, and then 10. So it's 300, 150, 100, 75, 60, 50, 40, 30, 20, and then 10. Now, alam niyo ba, ayan, sir, paano ba natin kukunin ang what na tinatawag na heart rate? Kunwari, ito yung mga straight line na. Kunwari, ito yung straight line sa ECG po natin. Maghanap ka ng QRS daw na nag-fall sa straight line. Okay? So, ito yon. Ito yung nag-fall sa straight line. Tapos, mag-start ka na mag-counting, guys, hindi dito, but rather dito. So, 300, 150, 100, up to the next QRS. Okay? Ayan, kunwari andyan yung next QRS. So meaning 100 po, no, ang heart rate ng patient natin. natin. Nakuha po ba? Ayan, at least na may mga styles na po tayo. So again, you memorize everything. 300, 150, 100, 75, 60, 50, 40, 30, 20, and then 10. Meaning to say, magsa-start tayo. Sorry. Dapat ganito kasi dapat yan eh. Kunwari lang ha, ganyan. Kunwari ganyan. Dapat wala yung kanina. Kasi start tayo ng counting from the first QRS up to the next QRS kasi. Ganito po dapat mag-count para mag-gets natin ang heart rate ng patient po. So meaning to say, ito yung first QRS mo, ito yung second QRS po natin. Pero magsa-start tayo mag-count, hindi dito sa first but rather dito sa second na line. So 300, 150, 100. So the heart rate of the patient now is 100 beats per minute po. Nagets po ba? Ayan, so ganyan po para makuha ang heart rate ha. I-memorize mo si 150, 300, 150, 100. Next po, we have here the rhythm. Guys, when we say rhythm po, sir, paano ba mag-check ng rhythm to know whether if it's regular or irregular? To know whether if it's regular, okay, or, ayan, irregular. Sir, regular yan pag the same distance. Pag not the same, ayan, not, okay, the same, okay, distance po, then ang tawag natin doon, irregular rhythm. So ulitin ko ha, pag regular po, the same distance. Pag irregular naman po, okay, not the same distance. And then, pag sinabi po natin, okay, rhythm, paano ba? No, how are we going to check for rhythm? You measure the distance. We need to measure, ayan, the distance, ayan, between P is to P wave, and then R is to R wave. Okay po? Ano ba itsura ng P is to P? Ito kasi ang P eh. Ito kasi yung QRS. Ito kasi yung, ayan, the T wave po natin. So we have here the, ayan, the P, diba? Ayan, no? We have here the Q, R, S, and then we have here the T wave. So guys, ganito yan. I-measure mo lang si P is to P is to P is to P. Pag the same distance yan, meaning to say it's regular. Pag R is to R is to R, pag the same distance, regular din po. Pero pag ginamit mo yung mata mo guys, sasabihin mo, ay wait lang, but parang hindi naman to the same distance. Okay, ang tawag doon, irregular. Okay po ba? Arrhythmic, okay, or arrhythmia, may arrhythmia ang patient natin. Na arrhythmic rhythm kasi yan eh. So therefore, may arrhythmia ang patient natin. No, or dysrhythmia, the same lang sila. So again, for the rhythm po, now we need to know whether if it's regular or irregular. And then we need to measure the distance between the P is to P and then R is to R. Now, aside from that, we have the P wave. Ito, kailangan malaman ang P wave. Why? Because P waves are basically the first names po of our ECG. Di ba? Yung mga sinus, atrial, ventricular. Ayan. Guys, don't worry. This will be a recorded, okay, lecture. So if ever you want to ask, for the said video, kung gusto mo siyang ulit-ulitin always, ayan, plano mo mag-take ng NCLEX, magagamit mo to sa NCLEX mo, As in like review, for the prometrics, for the HAAD, magagamit mo tong topic na to. Now, even sa NLE nga, meron na pong mga ECG, may mga ECG pharma na po sa NLE, sa board exam for nurses. Ay, matanong ko lang si Doc Melchor. Doc, ano po yung pre-med natin na course?
Biology po.
Biology. Ayan, tas sa Naga na din, Doc.
Apo.
Nice. Nice. Anong school sa Naga, Doc? Yung Naga ano nga yung nag-o-offer ng biology dyan, Doc?
Nueva Cáceres.
Ayun. Tama. Ayan, sige po. So we have here the P wave. Now for the P wave, guys, number one, if that's clear. If that is clear, and if that is upright, okay, in nature, next we have here the unclear. Ayan, or buried in nature. Ayan, so we have here the unclear, okay, and then we have here the buried. And then aside from unclear and buried po, and what if it's absent? Ayan, absent. Or basically purely QRS. If it's purely, ayan, QRS po. So again, we have the P wave, guys. If the P wave is clear, again, if that is upright, okay, in nature, then, okay, ayan, ang tawag natin doon, it's sinus. Sabay-sabay nga tayo. Pwede po mag-unmute. Everybody say sinus.
Sinus.
Ayan, great. Thank you, ma'am. Thank you po. So we have the unclear and if that's buried in nature. Ang tawag natin doon, it's atrial problem. Now, malalaman natin pag sinus, sir, if that is less than 150 beats per minute. It's sinus. Pero pag atrial problem po, it's greater than 150 beats per minute. Okay? So may leveling po tayo na from nakakatakot to mas nakakatakot at sobrang nakakatakot. Si sinus, yes, nakakatakot, lalo na si sinus bradycardia. Pero pag atrial tachycardia, no, mas nakakatakot. Pero may mas OA pa. Mas sobra pa sa nakakatakot. No? So that's where the absent and purely QRS. Ang tawag natin dito, these are the ventricular problems. Di ba? Familiar ba sa VFib or ventricular fibrillation? Diyos ko po. No? Pag yan ang mga nakita mo, di ba? We activate code blue dapat. Code blue to ER bed 1 please. Or code blue to San Lorenzo ward. No? Or let's say ano ba? Code blue to ICU bed 1. Na? So again, we have the P wave if that's clear and upright. No? We have the unclear buried. And then we have the absent and purely QRS. Sige po. So aside from guys, huwag mong kalimutan yan. So ano bang itsura ng clear and upright? Ganito pag clear and upright, pag ganyan ang P-wave mo, it's clear and it's upright. Okay po ba? Ayan. Pero pag pag unclear, mamaya, may clear illustration dyan. Huwag ko nang i-drawing kasi pangit ako mag-draw eh. Ayan. Now, aside from the P-wave, guys, we have the QRS complex. Now, for the QRS complexes kasi, now we have the normal, we have the narrowed, and then we have the widened, QRS. Guys, pag normal, pag narrowed, pag widened, iba-iba kasi yan eh. Usually, pag let's say normal ang QRS mo, and then normal sinus rhythm, or NSR, ayan, it's the normal sinus rhythm. Pag narrowed naman, baka may SVT ang patient natin or the supraventricular tachycardia or the narrow complex tachycardia or basically baka may atrial tachy ang patient natin. Pag widened naman po, expected guys, na may ventricular tachycardia ang patient natin or VTAC. Ayan. So we have the VTAC or ventricular tachycardia. So again, we have a normal QRS, we have the narrowed one, and then we have the widened. Usually halos the same kasi si narrowed at saka si normal eh. Ayan. So usually ganito ang itsura nila, di ba? P, tapos Q, ayan, RS, tapos ganon. So basically this one is narrowed, no, and normal. Pag widened kasi guys, pag ganyan ang itsura ng QRS mo. Ayan. And usually it's really common to patients who are suffering from VTAC. Kasi VTAC kasi are like swollen thumb. Idikit-dikit mo yung thumb na yan, widened, QRS ang tawag doon. Now, as we all know kasi ang VTAC po, pwede kasing with pulse at pwede din po siyang without pulse. Okay? So again, for the QRS guys, we have the normal, we have the narrowed one, and then we have the widened one or basically baka may VTAC po ang patient natin. Now, ano ba yung mga pinagsasabi ni sir? Like heart rate, no? Yung rhythm, no? Yung QRS ng P-wave. Now, balik tayo sa slides natin, ha? Okay, balik tayo sa basic form ng ECG po natin. Now, your ECG kasi, hindi porket ECG to, nakafocus lang tayo sa monitor. Kailang mag-focus din tayo sa patient din po natin. Because I have this experience na coming from my friend, na when we had the duty sa hospital, kasi nagtumakbo talaga siya. Sabi niya, Mark, nag-assistole ang client. Sabi ko, ha? Sure ka? Nag-assistole? Sabi niya, oo, kasi yun yung nakalagay sa monitor eh. Sabi ko, sige, anong gagawin natin? So malamang mag-activate tayo ng code blue. Sabi niya, sabi ko, hindi ba natin i-verify kung assistole ba talaga? Kasi di ba may protocols naman tayo sa assistole. Sabi niya, sige, i-verify mo. Basta ako, sure ako na nag-assistole. Diyos ko, nung paglapit namin kay kliyente, ang client nagte-text, no? Ang client nagchat-chat sa kanyang ex kasi parang nag-away ata. Tapos sabi ko, uy, bakit naging assistole to? Nagchat-chat pa naman, nagte-text pa naman. Sabi niya, baka lang to, baka natanggal lang yung mga leads natin. Malamang, baka natanggal lang talaga. So we need to check po the ECG leads. No? So ayun, natanggal nga. Sabi ko, buti na lang hindi tayo nag-activate ng code blue. Diyos ko po, no? IR siguro tayong dalawa. Kaya guys, ganito. The moral of the story po is that, di ba? We need to verify. We need to assess the patient first. na before mo sabihin na before ka mag-activate ng code blue or else IR ka talaga, na mapapagod lang yung code blue team natin, tas okay pala yung client mo, nagchat-chat pa, galit pa yung client mo, and how come naging asystole? Kasi sa asystole kasi, we have your 3 protocols kasi, di ba? Number 1, you check for the pulse. Pag check mo ng pulse, 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, there is no pulse, okay? Possible na asystole. We check for ECG leads. Doc, all ECG leads are in place. Maximize ECG 5 to 10 times. Asystole confirmed. Okay, asystole confirmed. So we need to perform class 1, class 2A, class 2B. Na? Ayan, so may sequence kasi tayo dyan. Mamaya, di-discuss po natin yan. Okay po? So we have the ECG, guys. Again, you verify your ECG. Wag lang sa monitor, but you need to na-verify that one to your patient. If nagkaroon ba talaga ng problema ang patient mo. Okay po? Ayan, so we have the electrodes. For the electrodes kasi, depende kasi yan sa defibrillator natin, whether you are using the biphasic or the monophasic na defibrillator. Now, let's say if you are using the monophasic, which is an obsolete one, guys, alam niyo ba hindi na po ginagamit ang monophasic? Kasi, there's this study po, pag monophasic kasi isang paddle ng defibrillator mo ang magbibigay ng charge let's say ng joules. Let's say pag sinabi ng doktor, ayan, let's defibrillate the patient charging to 360. Alam niyo ba ang 360 po? That's really common for monophasic. And then, yung study kasi, na may inautopsy sila na client, tapos nakita nila, they found out, na nasunog pala ang myocardial cells ni patient. Dahil, syempre, diba, gumamit ng monophasic. So, and malalaman mo din na obsolete po ang ginagamit ng ER nyo ngayon if they're still using the white, black, and red. Right side na, left side. White, black, and red. Pag smoke over fire pa rin or white, black, red, then hindi po updated ang mga equipment nyo. As in like, hindi talaga siya updated. Hindi po na-check ng ng tawag nito, ng DOH. Ayan, next we have the biphasic. Pag biphasic naman po, 2 paddles ang magbibigay. And yes, ito po yung recommended po ng World Health Organization, ng American Heart Association, and then of course ng Department of Health. Ayan. So sir, ano ba ang colors po natin? So we have it at the right side and then we have it at the left side. Pag red, yellow, green, red, yellow, and green ang ginagamit po. Pag red, yellow, green, yes, you are updated. Congratulations. So siya lang hospital nyo, delayed nga lang ang sweldo nyo. Charot. So we have the biphasic, guys. And malalaman ko pag biphasic. Monophasic kasi usually 360 ang sinasabi ng doctor dito 360 joules. Pero pag biphasic po, usually 150 to 200. 200 na yung max po natin. Ayan, bakit sir 200? Kasi biphasic So meaning isang paddle. 200 plus 200. A total of 400. Pero at least, hindi po masusunog ang heart po natin. Okay po? Ayan. Pwera na lang kung, di ba, as compared to your monophasic po, 360, boom, 360 agad. Dito 360 agad. Ayan. Kaya sunog talaga ang myocardial cells po natin. Okay po ba? Ayan. Now, sir, we are done na po sa ating electrodes. Now, let's proceed. So, we have the ECG paper, guys. Inside the ECG paper po, may big boxes. Ito yung big box mo. Ayan, big box. Zoom ko lang ha. Yes, that's your big box. Alam nyo ba ang big box po, it corresponds to 0.20 seconds. Sir, matanong ko lang, bakit siya 0.20? Kasi sa loob po ng isang big box, we have your 5 small boxes. Green ha, 1, 2, 3, 4, 5. And alam nyo ba, itong 5 small boxes, that corresponds to 0.04. So meaning to say 0.04 times 5, a total of 0.20 seconds. But wait, that's not our focus today. Our focus is that for us to immediately recognize na shockable ba ang rhythm na to? Non-shockable po ba to? Is it an arrest setting? Is it a pre-arrest setting? Okay? So, ganun po. No, yun yung focus natin. At hindi po magka-count ng mga seconds. Okay po? Ang importante lang, if ever kung ECG paper, you need to count for the said heart rate. Okay po ba? Ayan, sige. Let's discuss the waveforms. Let's say the P wave, di ba? The QRS, And then we have your, okay, the T wave. Tapos pag may ano pa dito, may U wave pa tayo. Alam niyo ba, ang U wave represents a slow heart rate? If ever kung may U wave ha. Ayan, i-discuss ko lang si PQRST. We have the P wave, the QRS, and then we have the T wave, and then we have the U wave. Sir, what if my pathologic Q wave? Ayan. So what if my pathologic Q wave? I-discuss ko na lang din ang what? Ang abnormal, ang U wave at saka ang Q wave po natin. Ayan. Or the pathologic Q wave. So when we say P wave, guys, that represents what? Atrial. Ayan, atrial depolarization. Pag sinabi kong depolarization, that means atrial contraction. Now, when I say QRS, this represents, okay, ventricular. Ayan, for a while. Ayan, ventricular. Yung pusa ko kasi. Wait. No, Roma. No? Sorry. Ini-scratch na kasi yung upuan ko eh. We have our ventricular, ayan, depolarization. And that's for the QRS. Now, when we say, ayan, no, T-wave po, this represents ventricular repolarization or nagre-relax na po. Next, your U-wave, guys, this represents, okay, what, na? Siyempre, slow heart rate. Why? Because, ayan, no, this is common to hypokalemic patient or patient suffering from hypokalemia. And then your Q-wave naman, pathologic Q-wave, di ba? Infarction or with myocardial, okay, infarction po natin. So ulitin ko, your P-wave represents atrial contraction. Your, okay, QRS naman po complex will represent ventricular depolarization. And then your T-wave po, it represents ventricular repolarization. Your U-wave represents hypokalemia. And then your Q-wave po represents, okay, infarction. Now, question. Sir, unfair ba sa atrial mo? Kasi wala siyang relaxation. The answer is yes. Tignan mo, oh. Ventricular contract, okay, magre-relax. Si atrial nag-contract, pero saan siya magre-relax? Anyone? Anyone who can tell me saan po magre-relax ang what? No, ang atria po natin? Or saan po nangyayari ang atrial repolarization? The answer is nasa QRS po. Inside the QRS po, dito din nag-what? Na nagre-relax. So we have the atrial repolarization also na nangyayari at QRS. So meaning dalawa po ang nangyayari sa QRS ha. Magko-contract ang ventricles pero kailangan ding mag-relax ng tinatawag na atria po natin. Kasi pag contract without relaxation, kawawa naman. So we need to contract, we need to work, and then we need to relax. We need to work, and then we need to relax. We need to work, and then we need to relax. Okay po? Hindi kasi pwedeng work lang. Okay? Ayan. Sige. So, kaya soon, excited na akong bumalik sa ano. Saan nga yun? Yung sa may Sorsogon. Yung ano, yung parang may villa. Saan nga yun? Sino mga taga Sorsogon dyan? Yung ano, yung parang may swimming pool. Yung loob ng, sa labas ng villa. Saan nga yun? Alam mo yun, Doc Melchor? Sa may Sorsogon, yung kay Heart Evangelista. Hindi, meron lang siyang ano doon. Meron lang siyang villa doon.
Nakalimutan
Ano
pa.
Yeah, pero 'di ba maganda doon? Sa Sorsogon 'yun eh.
Opo.
Yeah, nakapunta kasi ako doon eh kasama yung ex kong ano consultant. Pero pass. Naka-move on na po ako. Kaya ayoko na sa Bicol. Kasi ano ako, broken hearted ako diyan eh. We have for the PQR. Ayan, ST. Wala naman siguro nagwo-work dito sa ano na, sa ano nung hospital ngayon. BRT. Ayan, we have your PQRST, U, and then we have the Q, okay, wave na po. Okay po? Ayan, sige. So, we are done with the introduction po natin. So, ipakita ko lang din yung illustration natin. So, we have the P wave. We have the QRS. And then we have the T, okay, wave po. So P wave represents, okay, atrial depolarization or contraction. Your QRS na represents your ventricular, okay, depolarization or contraction. And your atrial, okay, relaxation or repolarization. And then your T wave po, guys, that represents ventricular, ayan, no, relaxation or repolarization. Okay po. Ayan, sige. Ayan, i-apply na natin yung mga learnings kanina na kung paano po mag-check ng heart rate kay patient. Again, it's your the 300, 150, 100, 75, 60, 50, 40, 30, 20, and then 10. So paano nga ulit? Maghanap ka ng QRS that falls on a straight line. Ito yung mga straight line mo. Oh. Maghanap ka daw ng QRS. Sige nga, ayun, ito. Ayun, na nag-fall sa straight line. Tapos nandito kasi yung next QRS natin. This is the first and this is the second QRS. So ganito ang counting natin ha. Start tayo sa red. Ito, 300, 150, 175. So meaning it's between 100 and 75 po ang QRS natin. So meaning to say pwedeng 80 ang heart rate, pwedeng 90. Guys, pasok ba siya sa 60 to 100? Yes. So wala po tayong problema dyan. Hindi po siya bradycardic, hindi din po siya tachycardic, but it's within the normal range po. Okay? Now, another example. Sige ha, another example. For a while. Ayan, ito. Maghanap ka ng QRS that falls on a straight line. Alam na this, no? Ayan na siya, oh. Ito na, 'di ba? Ayan. So ganito, mag-start tayo mag-count dito sa green line ko ha. 300, 150, 100, 75, 60, 50, 40. Ay. So it's between 50 to 40. So meaning to say, itong QRS na to, pwedeng 45, pwedeng 47, kaso it's below 60. So malamang it's a bradycardic one. Kasi hindi na siya na-belong sa 60 to 100 as for the normal range ng heart rate po natin. Okay po ba? Now another example, sige pa. Maghanap ka ng QRS that falls on a straight line. Ito sir, yes. Sige, mag-count tayo. Ito yung first QRS. Ito yung second QRS. So sige, let's count. 300, 150, 100. Okay, ang QRS po natin is between 150 and 100. So pwedeng 140, 130. Kaso it's above 100, so malamang tachycardic na ang client natin dito. Basta as long as within 150 to 100, guys, sinus problem yan. Kasi pag nag-greater than 150, atrial problem na po yan. Atrial tachycardia na yan eh. Pero pag less than 150 to 100, let's say 100 to 150, sinus tachycardia yan. Pero pag nag-151, 152, 153, so on and so forth, mga atrial tachycardia or the SVT or the supraventricular tachycardia. Okay po? Ayan. Now, aside from that, ayan, I need to know also the rhythm recognition, whether if it's regular or irregular. Now, gamitin ko tong ECG paper na to. Guys, di ba anong sabi ko? Mag-count ka ng P is to P or R is to R wave. Pag the same distance, regular ang tawag doon. Pag hindi po the same ang distance, irregular ang tawag doon. Tignan mo ang P, oh. Clear and upright, 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 clear and upright. Connect the dots. Okay. The same distance. Okay. The same, the same, the same, the same. Guys, pag the same, that means regular. Kung ayaw mo ng P is to P, sige, R, R, diba QRS, R, 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 R. Connect mo. The same distance? Yes. Kahit wala kang ruler, gamitin mo lang yung what? Na yung mga, syempre, mata mo. Na, ayan. Na? So, masasabi mo na the same ang distance. Ang tawag dito, it's irregular. Now, pakitaan kita ng irregular. For a while. Ayan. Pakitaan kita ng irregular ha. Okay. Tignan mo to Sige sir, zoom in tayo. Ayan, P is to P, is to P, is to P, 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 P. Wait lang. From, ayan, the same distance, okay. Pero ba't parang, ayan no, ba't parang naging smaller na ang distance? Ayan. Ayan. Naging shortened na po. Na? Kanina kasi parang longer, 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 tapos biglang naging shorter, shorter, shorter na. Hindi na the same ang distance nila. Ang tawag doon, irregular. or basically arrhythmia, no? Or dysrhythmic na po, na ang rhythm ng tinatawag na ayan, heart ng isang tao po. Okay? Ayan. Now, aside from that, discuss natin si P-wave. Si P-wave, sir, pag ganito ang itsura ng P-wave po natin, then malamang they are clear and upright. Clear and upright. Clear and upright, clear upright, clear upright. Tignan mo. Ito, alam mo to, it's T. T-wave mo yan. Ito, P-wave. Ito, T-wave. Ito, P-wave. Guys, pag nare-recognize mo pa, si T at saka si P, regular yon. Pero pag hindi mo na marirecognize, si T at saka si P, irregular na yun. Kasi that means buried na po, no? Ang P-wave po natin. Ano ang itsura pag hindi mo na siya marirecognize? Ganito ang itsura po, oh. Tignan mo. Hindi na ako sure, sir, kung saan na si P at saka si T. Kasi this is an example of an atrial tachycardia. Anong sabi natin? Pag atrial tachycardia, they are unclear and they are buried in nature. This is an atrial problem. Tignan mo ang sinus. Ay, ito alam ko pa to. T plus P. T plus P. Ito, ano to sir? P or T? Kaya nga the question is it clear or unclear? The answer is, it's unclear. So masasabi natin, a simple illustration, masasabi mo kung sino ang atrial tachycardia at kung sino ang sinus tachycardia dyan. This is your sinus tachycardia, your sinus rhythm. Clear pa po. Kaya nga sinabi ko clear and upright P wave. Clear and upright P wave. But if the P wave is buried preceding to T wave, meaning to say kinain ng tinatawag na T wave mo, ang P wave mo dahil gutom daw si T, kinain si P. Ulitin ko. Dahil gutom daw ang T mo, kinain niya si P mo. Na? So therefore, that's where the atrial tachycardia. Okay po ba? Ayan. Let's begin na po by simply having the sinus rhythm. Magsa-sinus rhythm na ako ha. Kasi ito, na-discuss na natin yan eh. Ito ang itsura ng wide QRS and that signifies may VTAC ang patient. Pag narrowed QRS, may SVT ang patient, or the narrowed complex tachycardia, or the atrial tachycardia. And then we have the normal QRS, syempre NSR. Guys, huwag mo na mabalik ta rin to SNR ha. It should be NSR. Kasi pag SNR, mga pizza po ang lalabas sa monitor po natin. Oy, may SNR na ba sa Naga? Meron na ba? Kasi sa pagkakaalam ko last time, like 2 years ago, grabe, bilis, no? 2 years ago na pala. So 2 years, hindi, 1 year pa ata. Parang 1 year pa. So 1 year pa akong single. So, ayun. Ang pagkakaalam ko kasi sa sa Legazpi, magkakaroon ng SNR. Meron na bang SNR doon? Ayan, may SNR na kaya
Wala pa po.
doon?
Wala
Ay,
pa.
wala pa. Si Doc Melchor. Wala pa, Doc, na? How about in Naga, Doc? May SNR na ba?
Wala rin po.
Wala rin. Married na po ba si si Doc Melchor?
Hindi po.
parang ayaw niya muna magpakasal. Ayan, ano muna Doc na rounds muna, 'di ba? Yan, bubuo pa muna siya ng hospital. Ano po yung specialty natin, Doc Melchor?
Wala pa po.
Magsa-start pa lang, tama? Oh, nice, nice. But if given a chance, Doc, saan mo gusto?
Hindi ko po alam. Wala
Hindi
pang...
undecided pa. Ayan. Pero parang feeling, ay, ikaw yung naligo kanina, tama? Na naka-on ang camera? Sabi ko, parang kalimutan ata ni Sir eh, no? Parang wait lang, sino ba to? Ayun, si Doc nga. Siguro kagagaling lang ng duty ni Doc, tama ba? Nag-rounds ka ba galing, Doc?
Hindi po.
Pero nag-work ka na ngayon sa hospital, Doc, tama?
Opo.
Nice. Ayan, sige. Kasi nakita ko si Doc Melchor ang gwapong doktor. Ayan. So we have the wide QRS, we have the narrowed QRS, and then we have the normal QRS, which is the NSR. Let's begin na po with our normal sinus rhythm. Now, for the normal sinus rhythm, guys, a quick introduction po. Ang sabi kasi ng American Heart dito, we are following the 2020 guidelines with COVID protocols. Okay po. Then I'll be sharing videos later. Alam niyo na ba ang latest po na status ng COVID guys sa John Hopkins? As of today, nag-check po ba kayo? Nag-check ba kayo ng John Hopkins ngayon? Sige, i-share ko din ha. Ayan, regarding John Hopkins. Kasi parang, yeah, may mga may mga iba na bumababa ang case, no? Meron ding sobrang OA na naman ang case. Pero kasi kahapon, when we had the parang convention, no? Yeah, number 1 pa rin si US. Wait lang ha, check ko ang global map ngayon. Para at least may mai-share naman ako sa inyo regarding sa COVID na update na po. As of now, guys, Diyos ko, ilan na ba to? Naglo-loading pa siya. Naglo-loading pa po. Ayun, wait lang. Gusto ko ding ma-update din as of today. As of this moment po. Yeah, the cases and deaths na by country and region, sovereignty. Tagal naman nila mag-update. Ayun, US pa rin po. Cases ng US guys, 34,440,980. Ang deaths po nila, 610,887. Nakamusta naman 'yon? Pero globally yeah, global cases po, ano ba 'to? Parang basta yun lang ang nabasa ko sa sa US. How about sa sa Philippines? Sa Philippines po ngayon guys, as of this moment ha, we have 1,548,755 cases ng COVID. And then ang total deaths na po, Philippine setting, 27,224. Ayan, tapos ang vaccinated na po, vaccine doses administered globally, billion na to 3,841,933,029 na doses na po ang naibigay globally. Yeah, kasi ngayon guys, honestly, nag-volunteer kasi ako sa Rescuna kasi wala pa kaming work no, as clinical instructors din po sa isang sikat na university here in Davao City, and which is my alma mater din. So ayun, nag-volunteer muna ako. And then tomorrow po, we will be administering the Sputnik, the Gamaleya. Na if you're familiar po sa mga vaccines. Ayan, Doc Melchor, kamusta po ang ang mga res bakuna diyan sa Bicol? Parang feeling ko wala masyado kayong mga vaccines, no? Wala, no? Napansin ko, Sir Arfi, naka-mute ka. Wala masyadong bakuna sa inyo, sa may Bicol area. Ewan ko ba, siguro mga immortal siguro to.
Meron naman sir, kaya lang mabagal yung konti pa lang
Mabagal.
konti pa lang yung dumadating daw na vaccine.
Yeah. Kaya nga 'di ba? Actually style 'yan ng ibang lugar na dapat paparamihin yung cases. Kasi the more maraming cases guys, the more mapupunta sa inyo ang mga bakuna. O kaya sabihan niyo yung mga corrupt na mga officials. But I'm not saying sa Davao ganun ang nangyayari. Pero luckily in Davao City, like sobra OA lang kami sa vaccines dito guys. Sobrang. Like we usually cater every day like 500 doses, no? 500 doses or 1,000, 500 to 1,000. See? Pero ang inuuna po namin is yung mga government na employees, syempre mga frontliners like us na nauuna po sila. And then yung mga iba na nagpapagawa ng mga medical cert para masabing A3, 'di ba may mga asthma, tas nakakatawa. Ma'am, 'di ba A3 ka? Na ano po yung mga maintenance po natin? Sabi ko, tas tinanong ko din siya, ma'am, ano ba yung sakit mo? Sabi niya asthma. Sabi ko, ano maintenance mo, ma'am? Sabi niya paracetamol, no? Sabi ko, ay try harder. Alam na, pinagawa lang tong mga med cert na to Halata naman Yung iba din guys at the second dose, sir, ano yung comorbid po natin? Sabi niya wala. Di ba A3 ka? Sabi niya, yes, asthma. Ay, kinalimutan ang comorbid niya. Kinalimutan ang asthma. Nawawala pa lang asthma ngayon. Ayan. Sige po. Controlled lang siguro pero hindi siya nawawala. Grabe. Ayan. So we have the sinus rhythm po. Guys, when we say sinus rhythm, ayan, ang sabi ng American Heart ganito. That doesn't mean na sinus rhythm yan, na you will exclude them na from having cardiac problems. Meaning to say, di porket sinus rhythm ay hindi na sila magiging abnormal later. Posible pa rin. Kaya no, you need to monitor pa rin your patient po or else na biglang maging from rhythmic po biglang karoon ng arrhythmia ang patient natin. No? Pwedeng magkaroon ng dysrhythmia ang patient. So you need to monitor pa rin the patient. Now you check vital signs pa rin po. Yun yung pinaka-importante sa lahat. Okay po ba? Now, with your sinus rhythm kasi everything is normal here. As in like normal lahat dito. From heart rate up to the QRS. Na? And na-discuss naman na din po natin. Sige nga, check natin ang kanyang heart rate. Ayan, ito gusto ko to. Pwede na yan. Check tayo guys. Let's begin counting. Start. 300, 150, 100, 75. So the heart rate of the patient here is 75. Pasok ba siya sa 60 to 100? Yes, meaning normal ang heart rate. The rhythm is what? Regular or irregular? Guys, ang rhythm niya, regular, irregular? The same ba ang distance nila? Yes.
Yes, sir.
P is to P, is to P, is to P, is to P. The same distance? Yes. Meaning regular yan. Can you see P wave? Yes. The P wave here is clear and upright. Clear and upright ang P wave, oh. Clear and upright ang P wave. Clear and upright. So if that's clear and upright, check, 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 sinus yan. Tapos balikan mo ang kanyang heart rate, normal. So meaning normal sinus rhythm. Kasi guys, pag clear and upright, tapos ang heart rate niya less than 60, sinus bradycardia ang tawag doon. Pag ang P wave niya is clear and upright, tapos ang kanyang heart rate is above 100, edi sinus tachycardia ang tawag doon. Did you get me? So meaning to say, upon listening lang po, magigets na po natin kung ano ang nangyayari kay patient. Try to what? No, try to visualize, na? Kahit sasabihin ko lang, the heart rate of the patient, guys, is 38. The rhythm is regular. The P waves are clear and upright. Followed by QRS, which is narrowed, na, and normal in nature. So therefore, the patient is suffering from what? Sinus bradycardia. Kasi you listen lang sa heart rate and then you're gonna listen po sa what? Sa P wave ng patient. Okay? Now, next topic, we have the sinus. Ayan, bradycardia. Alright. Now, for the sinus bradycardia naman, alam niyo ba this is really common na 2A's po natin? Sino yung mga 2A's natin? Number one, we have the athlete. Yung mga athletes po natin. Di ba? Hindi yung athlete's foot na mga athletes, right? Mga basketball player, etc. Basta yung mga na-engage sa sports po natin na tapos nakipag-compete, di ba? Lalo na ngayon at Olympics po ngayon. Tama po ba? And Olympics na, ayan. So, syempre, Olympics kasi, ayan. So, medyo magulo na naman yung mga Facebook natin, etc. Now, guys, pansinin yung mga athletes. Pag sila ay tumakbo, let's say 100-meter dash, pag-check mo sa kanilang heart rate, baba pa rin. Kasi sanay na ang heart nila eh. 'Di ba? Pero pag ako pag tumakbo ako ng 100 meter, siguro sa 50 meters pa lang guys, siguro nag-VFib na ako guys, no? Or much more na mag-asystole na, 'di ba? Depende kasi talaga sa tao 'yan eh, no? Ayan, just ko. So we have our letter A, asleep. Pag mga taong tulog. Guys, sino ba ang mahirap gisingin? Ang taong tulog or taong tulog-tulugan? Siyempre, mga taong tulog-tulugan. Ito yung mga pinakamahirap po na nagisingin. Kahit, Diyos ko, kahit dumugo na yung ilong mo, dumugo na yung bibig mo sa kakasigaw, ayaw nila pa rin. Ito yung mga kapatid po natin, lalo na pag-uutusan mo. Oy, maglaba ka na, di ba? Or magugas ka na ng pinggan. Ay, ayaw talagang magising eh, no? Ayan, yun yung mga taong tulog-tulugan. Tapos pag nagising na, tas inutusan mo, nagiging paniki. Di ba? Bakit nagiging paniki, sir? O maghugas ka ng plato, ba't ako? O magwalis ka na doon, ba't ako? Paniki ka, girl. Puro ka, ba't ako? And we have the athlete and then we have the asleep. Guys, ang problem po natin with sinus bradycardia, sige nga, ayan, sabay-sabay tayo, guys. You can unmute na para ma-check ko kung okay pa kayo dyan. Everybody say bradycardia.
Bradycardia.
Ay,
Bradycardia.
ang galing, no? Andyan pa pala talaga sila eh, no? I love this group kasi may mga moments na okay, no? Parang doon na lang sila sa recording kasi somehow busy kasi sila pero I understand, na buti guys at pumayag kayo ng Monday. No? Buti at pumayag kayo ng Monday po. May training ba kayo nung Sunday? Wala.
Wala po, sir.
Wala. Saturday lang.
Saturday lang, sir.
Yeah, Saturday. Na kaya inappoint ako ni Ma'am Joy na ng Saturday. Sabi niya, Sir Marky, baka mag-lecture ka ng either Monday or Sunday, na kasi nagre-rest bakuna din kasi ako eh, na although originally iba kasi yung yung instructor. Baka sabihin niyo ako yung hindi ako yun. So we have sinus bradycardia. At least na nai-push talaga. Kaya sabi ko, yes ma'am, walang problema ma'am, na basta ikaw. Na? Ayan, so we have the sinus bradycardia pa. So we have the athlete and we have the asleep. Guys, ang rate kasi natin for sinus bradycardia, dito kasi, ito yung problema natin, no? Ang heart rate ng patient. Why? Because the heart rate here is less than 60 beats per minute. Kaya nga, di ba, pag less than 60 po, bradycardic ng patient natin. The rhythm here is regular, walang problema. The P waves, walang problema. Walang problema to, walang problema, walang problema. Ayan, wala. Ito lang talaga. See what? Na ito yung naging abnormal dito eh. It's your sinus bradycardia. Guys, ganito. Paano ba tinitreat ang sinus bradycardia? Depende kasi sa patient yan eh. If your patient is an adult client, we usually give atropine sulfate. Pero if the client is a pediatric patient, we usually give epinephrine. Especially if you're going to enroll yourselves po sa PALS or the Pediatric Advanced Life Support, maganda din yon. Okay? Ayan. For the sinus bradycardia, ayan. Na ano bang itsura ng sinus bradycardia, sir? Sige nga, mag-check tayo. Maghanap ka ng QRS that falls on a straight line. Ito, sir. Ayan siya. Huwag ka sa red mag-start na mag-count. Dito ka mag-start sa next line. Sa straight line natin. 300, 150, 100, 75, 60, 50, 40. So it's between 50 to 40 guys. So hindi po siya kasama sa 60 to 100 which is normal. So it's below normal. So definitely this one is a bradycardic patient. So ang tawag natin, it's sinus bradycardia. Now, let's assume na let's say 45 ang heart rate. Paano mo basahin yan? The heart rate here is 45. The rhythm is regular. I can see P waves. They are clear and upright, followed by QRS, which is narrowed and normal in nature. Ayan. The patient here is exhibiting sinus bradycardia. Okay po? Medyo dumarami na po tayo. Ayan. Sa mga na-late po na pumasok, pwede naman po na mag-avail ng recorded natin na lecture. Ayan, kasi for sure yung iba, they are working po. Na, ayan. Pero since pumayag po kayo na Monday, ayan, thank you po. Thank you. Ayan. So we have here the sinus arrhythmia. Guys, when we say sinus arrhythmia, from the word itself, arrhythmia, dysrhythmic to eh. Meaning to say, pag dysrhythmic po, ayan, no? So wala pong wala po tayong regular na rhythm dito. Okay? Ayan, so we have the heart rate here. The heart rate is normal. Walang problema nasa heart rate. Ang problema lang po natin dito is of course the rhythm because the rhythm here is abnormal ang rhythm. Hindi siya regular. Tignan mo Kung i-connect the dots natin, ayan, connect the dots. Hindi talaga siya the same ang distance. Ayan. Sa P is to P is to P is to P. So irregular na siya. So pag irregular po, arrhythmia ang tawag doon. Now, here's the catch. For sinus arrhythmia, expected na normal ang heart rate ni patient. The problem here is that of the rhythm of the patient. No problems with the P wave, no problems with the PR interval, no problems with your QRS. But the problem is of course the rhythm lang. Okay? So ang tawag natin dyan, it's the sinus arrhythmia. Usually binibigay po ng doctors po yung mga antidysrhythmic drug such as yung mga lidocaine, yun po yung mga binibigay. Yung mga procainamide ayan, sige po. Sometimes nagbibigay na din ng mga amiodarone, pero kasi yung amiodarone kasi may specific talaga na ECG para doon. Dito kasi mga ano lang, mga antidysrhythmic na very common is the procainamide. Okay po? Now, let's discuss sinus tachycardia. Right after sinus tachycardia, siguro may mga ipapakita akong video. Okay? Kasi be my last topic for sinus problems. Ayan. Again, for sinus tachycardia, sir, kailan ba common ang sinus tachycardia? Usually, every 9:30 nagpapabreak po ako. Ayan. Sir, ganito. For sinus, ayan, tachycardia, what are the possible, common, reason or common causes? So we have here the F's, guys. Ayan, very common po, no, na nagkakaroon ng sinus tachycardia ang mga taong may fever. Pero nakakatakot po ang mga may fever ngayon. Tapos may mga dry cough, 'di ba? Ayan, tapos may mga sore throat, just ko po. Next, we have the fever, we have the fatigue. Ayan, or na stress ang patient po natin. Next, we have the fluid loss. So we have the fluid loss. And lastly, we have the what? Na the letter F. Pag in pain ang patient. Pain yan, guys. However, F kasi so pain na lang. Pain. So we have the fever, the fatigue, the stress, the fluid loss, and then we have the pain. These are the reasons kung bakit daw nagkakaroon ng tachycardia ang patient natin. So we have fever, fatigue, fluid loss, pain. Itong pain talaga, sobrang totoo talaga to. Hindi lamang ang what? Hindi lamang ang let's say heart rate mo ang tataas, even your BP tataas din po, 'di ba? Ayan. So again, expected na pag ikaw ay may mga ganitong mga symptoms, expected po na magkakaroon ka rin ng sinus tachycardia. Are you still with me? Yes na yes,
Yes, sir.
Ayan, sige po. Thank you. Ayan. So at this point in time, magbe-break na muna tayo. Okay? Ayan. Pero ito, discuss ko muna to. Ayan. Sinus tachycardia with the rate of, ito babaguhin ko to. Hindi dapat siya 180, but rather 150 dapat yan. 101 to 150 para masabi mong sinus problem. Kasi pag 151 onwards, ang tawag doon atrial problem na yan. The rhythm here is regular, walang problema. However kasi, ang heart rate natin dito is abnormal, mataas talaga. Sige nga, maghanap tayo ng QRS that falls on a straight line. Ito ba yon? Ito ba yon? Yes, yan ha. Tapos mag-start tayo, guys. Para sa mga bago po, ang counting kasi is 300. May mga bago kasi 150, 'di ba? 100, 75, 60, 50, 40, 30, 20, and then 10. So mag-start po kami na mag-count from the first, no, QRS up to the next QRS. So dito kami mag-start. Wag dito, guys, pero dito 300, 150, 100. Up to the next QRS kasi yan. So meaning it's 150 to 100. So ang heart rate ng client mo, it's within 100 to 150. Hindi siya lumagpas ng 150, so sinus siya. Kasi pag 151 na yan, atrial problem na po yan. Okay po? Yes na above 100 siya, so tachycardic ang client. So the patient's heart rate, I presume na 120 ang heart rate ng client natin. Okay? So the heart rate is 120 or 120. The rhythm is regular. I can see P waves. They're clear and upright, followed by QRS, which is normal, in nature. So therefore, the patient is having or is experiencing sinus tachycardia. Okay po? Ayan. Sa mga kakapasok lang, matanong ko lang. Ayan. Hello, ma'am, Adele Ojeda. Doctor po ba, ma'am, or nurse po? Pwede pong mag-unmute, ma'am, ha? Ma'am, nurse po or doctor po?
Doctor po.
Ay, hello, Doc Adele.
Oo
Maayong
nga.
buntag, Doc, from Davao.
Ayos lang kung may nag-arrest, kaya nalita ko.
Okay lang yan, Doc. No? Ayan. And extra
Salamat.
careful. Taga saan, Doc, na hospital?
Bulan. Sa Bulan Hospital.
Nice. Welcome
Sir
to
po.
WePump, Doc. Welcome to WePump po.
Thank you.
Ayan, thank you po. How about si Sir Paul Respicio? Ay, si Sir Paul ba yung kanina? Nasa ambulance na na PNP? Tama po ba? Or hindi ko pa, hindi. Ay, hindi. Hindi ko pa natawag si Sir Paul. Si Sir Paul po ba ay nurse or doctor po?
Medtech.
Ay, medtech, tama. Sorry. Si Sir Paul, naalala ko na. Kanina, sorry. Ayan. So siguro nasa mga ano tayo ngayon, nasa mga 15, halos 15 daw. Ayan, or 11 or parang ganon. Ayan, so again welcome to WIPAM po. I am Mark Adlawan, all the way I'm from Davao City pa. Ayan, so ayun. So I'll be having the since almost 9:30 na po. So let's have the break. Pero habang nagbi-break kasi kayo guys, nagpapa-show talaga ako ng video based on AHA. And okay, this is a quick quick recall lang po, or let's say quick na video lang po regarding airway management na. So while having your break po. So let's have the break for 20 minutes only, and then magpi-play ako ng video ha. Sige po.
And clearing the airway.
Guys, this is based on the 2020 guidelines of your American Heart Association. So listen carefully.
Managing a patient's airway is a fundamental life-saving skill, one that both basic and advanced healthcare providers should be able to perform well. Airway management is one of the key interventions for BLS and ACLS. It is critical before, during, and after cardiac arrest. The optimal method of managing the airway will vary based on provider experience, training, scope of practice, EMS or healthcare system protocols, and the patient's condition. We'll review effective bag mask ventilation using both single and two-person techniques. We'll review the steps of responding to a respiratory arrest and the recommended use of waveform capnography to monitor and confirm the placement of advanced airways. Before we get into the specific airway skills, let's review the recommended ventilation rate for cardiac arrest patients. For patients in cardiac arrest, provide 2 ventilations with the bag mask device after every 30 chest compressions. After inserting an advanced airway, healthcare providers should continue ventilations by providing asynchronous ventilations once every 6 seconds. If a patient is in respiratory arrest and has a pulse but is not breathing, ventilate once every 5 to 6 seconds. After 2 minutes, reassess the pulse. When giving ventilations, healthcare providers should avoid excessive ventilation or administering tidal volumes that are too large. Not only can this cause gastric insufflation and aspiration of gastric contents, but excessive ventilation also increases intrathoracic pressure and decreases venous return to the heart, so it lowers cardiac output and the patient's chance of survival. Tidal volume should be approximately 500 to 600 milliliters, enough to see the chest rise. This is about half a squeeze of an adult ventilation bag. Let's begin with basic airway skills. The first 2 steps in any airway management response involve opening and clearing the airway. First, open the airway by using a head tilt chin lift maneuver. Place one hand on the forehead and one on the chin, and push with your palm on the forehead to tilt the head back while lifting the jaw to bring the chin forward. This simple maneuver lifts the tongue from the back of the throat, opening the airway. This procedure is typically performed on patients without any evidence of head or neck trauma. In patients with suspected cervical trauma, a jaw thrust without head extension is used. In a jaw thrust maneuver, place your fingers just under the angles of the lower jaw and lift with both hands, displacing the jaw forward. If the jaw thrust does not open the airway, use the head tilt chin lift, because maintaining a patent airway is a priority. The second step is to clear the airway. Providers should suction the airway immediately if there are copious secretions, blood, vomit, or a foreign body. Use large bore, non-kinking suction tubing and a large suction catheter with a rigid pharyngeal tip. High suction pressure may be required. Once the airway is open and clear, you may consider use of an airway adjunct to maintain a patent airway. There are 2 types of airway adjuncts: the oropharyngeal airway, or OPA, and the nasopharyngeal airway, or NPA. OPAs are commonly used for patients who are unconscious and have no gag reflex. NPAs may be used for conscious, semi-conscious, or unconscious patients with or without a gag reflex. The OPA is a J-shaped, single-use, disposable plastic device. OPAs are available in various sizes, with the most common adult size ranging from 8 to 10. Here's how to choose the correct size OPA. Place the OPA against the patient's cheek. When the flange of the OPA is at the corner of the mouth, the tip is at the angle of the mandible. A properly sized and inserted OPA results in proper alignment with the glottic opening. To use the adjunct, insert the OPA so that it curves upward, with the tip pointing to the hard palate. As the OPA passes through the oral cavity and approaches the posterior wall of the pharynx, rotate it 180 degrees into the proper position. Alternatively, the airway can be inserted sideways and rotated 90 degrees into place. Once properly inserted, the OPA holds the tongue away from the posterior wall of the pharynx. It also provides access to the throat for suctioning and prevents the patient from biting an advanced airway. OPAs that are too large may obstruct the larynx or cause trauma to the laryngeal structures. OPAs that are too small or inserted improperly may push the base of the tongue posteriorly and obstruct the airway. Healthcare providers should insert the OPA carefully to avoid soft tissue trauma to the lips and tongue. Remember to use OPAs only in unresponsive patients with no cough or gag reflex. If the patient has a cough or gag reflex, the OPA may stimulate vomiting and laryngospasm. Only healthcare providers trained in the proper use of an OPA should attempt its insertion. The NPA is a soft, curved, hollow tube that can be inserted through the nostril to facilitate ventilation and suctioning. Unlike oral airways, NPAs may be used in patients who are conscious, semi-conscious, or unconscious, with or without a gag reflex. In choosing the correct size, make sure that the length of the NPA is the same as the distance from the tip of the patient's nose to the earlobe. Before inserting an NPA, lubricate the airway with a water-soluble lubricant or anesthetic jelly. Insert the NPA through the nostril in a posterior direction perpendicular to the plane of the face. Using moderate pressure and a gentle spiral motion, push the device into the nostril. When inserted correctly, the NPA should reach beyond the nasal cavity to the pharynx, providing a clear path for ventilation and suctioning. If you encounter resistance during insertion, gently withdraw the NPA a centimeter or so, slightly rotate it, and gently try to insert it again. If you continue to encounter resistance, withdraw the airway completely. You may try inserting it in the other nostril. Use caution when inserting the NPA in patients with severe head or facial trauma because of the risk of misplacement into the cranial cavity. With a known basal skull fracture, an oral airway is preferred. Take care to insert the NPA gently to avoid complications such as tissue injury or bleeding. An NPA may also cause laryngospasm and vomiting. An improperly sized NPA may enter the esophagus and cause gastric inflation with active ventilation. After inserting either an OPA or NPA, it's important to check whether the patient is getting adequate ventilation by listening for breath sounds. During resuscitation, patient ventilation is commonly provided with a bag mask device. First, let's look at the device itself. A bag mask device is composed of a self-inflating or flow-inflating bag that is attached to a clear, cone-shaped face mask that covers the patient's nose and mouth. The edge of the mask has an inflatable cushion, enabling a tight seal around the nose and mouth when the provider applies pressure to the mask and lifts the jaw. Now, let's see how to properly use a bag mask device. First, position yourself directly at the top of the patient's head. Place the mask over the patient's face. Before providing bag mask ventilation, the provider must first perform a head tilt and then press the mask against the face while lifting the jaw into the mask. This is best achieved by forming a C with the index finger and thumb of one hand on the top side of the mask at the bridge of the nose. This motion firmly secures the mask to the face. At the same time, the 3 remaining fingers form an E and should be used to lift the jaw, opening the airway. While maintaining a tight seal between the patient's face and the mask and maintaining a jaw lift to open the airway, the provider should squeeze the bag, taking about 1 second to deliver 1 breath. For a patient who has spontaneous circulation but needs ventilatory support, the provider should give rescue breaths at a rate of 1 breath every 5 to 6 seconds. An effective breath results in visible chest rise. The most effective way to deliver bag mask ventilation is to use the 2-person technique. The first provider focuses on keeping the airway open and securing the mask, while the second provider delivers ventilation with the bag. The first provider uses both hands to seal the mask to the patient's face and lift the jaw. The thumbs and index fingers of both hands each form a C, ensuring a good mask seal against the face, with the 3 remaining fingers of each hand forming the E, lifting both sides of the jaw into the mask. The second provider squeezes the bag enough to cause visible chest rise. When using a bag mask device, whether there are 2 providers delivering breaths or just 1, be careful not to press too hard on the mask, which could push the patient's jaw down and obstruct the airway. There are several possible indications for insertion of an advanced airway. These include difficulty providing effective bag mask ventilation, patients with actual or potential airway compromise, particularly with long transport times, or the need to isolate the airway. With careful attention, trained healthcare providers can use an advanced airway to safely provide ventilation that is as effective as bag mask ventilation. Advanced airway devices offer many advantages. These include isolating the airway and reducing the risk of aspiration and gastric insufflation. After inserting an advanced airway during CPR, providers should deliver 1 breath every 6 seconds without interrupting chest compressions. Unfortunately, insertion of some advanced airway devices, like an endotracheal tube, may require interruptions in chest compressions that last longer than 10 seconds. These interruptions may reduce survival rates for VF arrest patients. It should also be noted that there is no evidence that advanced airway measures improve cardiac arrest survival rates in either in-hospital or out-of-hospital settings, so providers must carefully consider all these factors before performing the intervention. There are other advanced airway devices that healthcare providers can often insert without interrupting chest compressions. These include supraglottic devices, such as the laryngeal mask airway, the laryngeal tube, and the esophageal tracheal tube. Healthcare providers who use advanced airways within their scope of practice must maintain their skills by using them frequently. The American Heart Association recommends that you become familiar with a variety of devices, but master one primary method of advanced airway control. If you're unable to establish an advanced airway, continue ventilation with a bag mask device. The laryngeal mask airway is a supraglottic airway device that healthcare providers can insert without visualizing the glottis. In addition, it can be inserted during CPR while chest compressions continue uninterrupted. This makes training easier and insertion more reliable. The laryngeal mask airway is a tube with a distal inflatable cuff shaped like a mask that is placed in the patient's hypopharynx. Place the laryngeal mask airway in the open mouth with the opening of the mask facing the patient's tongue. Advance the device to the back of the tongue. In a smooth motion, use your index finger to press the laryngeal mask airway against the roof of the mouth and guide it downward. Continue advancing the device until you feel resistance, which indicates the distal end of the tube has reached the hypopharynx. Withdraw your finger and inflate the mask. Once inflated, the laryngeal mask airway will center itself in the mouth. If placed correctly, oxygen will flow through the lumen of the device and into the trachea. The laryngeal tube is a supraglottic device that can be inserted in an unconscious patient. Providers can insert the device during CPR while chest compressions continue. The device can also be inserted without visualizing the glottis. The laryngeal tube is a single lumen device with two cuffs inflated through a single inflation port. The distal tip of the tube is angled and beveled to easily slide into a collapsed upper esophagus. The design also reduces the likelihood of tracheal insertion. When the tube enters the esophagus, you should feel resistance. Inflate the cuffs with a single syringe. The esophageal tracheal tube is a supraglottic device that providers can insert during CPR without interrupting chest compressions and without visualizing the glottis. The esophageal tracheal tube is made up of two lumens permanently joined. Each tube can be used to provide oxygenation and ventilation, depending on how it's inserted. The longer blue tube, marked with a number 1, provides ventilation through 8 small side openings of the lumen in the pharyngeal section. The shorter, clear tube, marked with a number 2, provides ventilation directly through the lumen to the end of the tube. Once the tube is in place, use the large blue syringe to inflate the pharyngeal cuff through the port labeled number 1. Then use the smaller syringe to inflate the distal cuff through port number 2. The distal tip of the device will rest in either the esophagus or the trachea. If the tube rests in the esophagus, which happens most frequently, the cuff blocks airflow in and out of the esophagus, and ventilation occurs via lumen number 1 and through the small side openings into the trachea. If the tip of the tube comes to rest in the trachea, however, the rescuer can use lumen number 2 to deliver ventilation directly into the trachea. Caution: it's critical to confirm the proper placement of the esophageal tracheal tube, because if ventilation is delivered to the incorrect lumen, it will prevent adequate oxygenation and ventilation and result in severe hypoxia. Incorrect delivery of ventilation to the esophagus will also produce gastric insufflation that will complicate ventilation. The endotracheal tube was once considered the optimal method of managing the airway during cardiac arrest. However, intubation attempts by unskilled providers or by providers who use it infrequently can produce serious complications, such as trauma to the oropharynx, incorrect placement in the esophagus or right main bronchus, and prolonged interruptions in compressions and ventilations. Despite the risks of intubation in inexperienced hands, there are many benefits to endotracheal intubation. These include keeping the airway patent, allowing suction of the airway, speeding the delivery of high concentrations of oxygen, providing an alternative route for some drugs when intravenous or intraosseous routes are not available, and, when using a cuff, potentially protecting the airway from aspiration. The endotracheal tube is a single clear lumen with a single cuff. To insert the endotracheal tube, place the patient's head in the sniffing or neutral position. Insert the laryngoscope blade into the patient's mouth. Lift the laryngoscope vertically up and away to expose the vocal cords and glottic opening. Insert the endotracheal tube directly between the vocal cords and into the trachea until the cuff passes the cords. Once the endotracheal tube is in place, inflate the cuff and attach a waveform capnography monitor to confirm proper tube placement. When choosing to use an advanced airway, you need to be confident that it is inserted correctly and that you're providing effective ventilation while avoiding excessive ventilation. Watching for chest rise, checking for bilateral breath sounds, and listening for gurgling sounds coming from the stomach can help you confirm the placement of an advanced airway. Beyond these clinical assessments, there are several devices that can help you determine whether you have inserted the airway correctly. Waveform capnography monitors how much carbon dioxide is exhaled by the patient. The American Heart Association recommends using waveform capnography to confirm and monitor the correct placement of an endotracheal tube. Scientific studies have not yet validated waveform capnography as a method of confirming proper placement of supraglottic airways. However, effective ventilation through these airway devices should produce a capnography waveform. A normal end-tidal CO2 waveform looks like this. The measurement of the amount of end-tidal, or exhaled, carbon dioxide can be shown as a waveform, where the carbon dioxide level goes up when we exhale and falls back to 0 when we inhale. Even when healthcare providers are properly ventilating the patient, chest compressions will produce a low end tidal CO2 reading because even the best CPR produces cardiac output and pulmonary blood flow that's about 25 to 30% of normal. In contrast, ROSC can cause an abrupt increase in end tidal CO2. Waveform capnography devices that display both a waveform and a number will give you the most comprehensive information. Connect the monitor between the advanced airway and the bag or ventilator. Waveform capnography provides a graphic demonstration of the carbon dioxide exhaled with every breath. Humans with healthy lungs have a characteristic waveform that is divided into 4 phases that occur during inspiration and expiration. When the patient first begins to inhale, the curve falls sharply to 0. As the patient continues to inhale, the reading on the monitor should remain at 0. When the patient first exhales, the initial portion of the breath consists of the air in the dead space from the breathing tube and the trachea. As air from the alveoli begins to empty into the circuit, carbon dioxide levels start to increase. This is shown as an upward deflection at the beginning of the exhaled carbon dioxide curve. As exhalation continues, carbon dioxide continues to pour out of the lungs until the next breath is initiated. The highest value in the curve is called the end tidal CO2. For patients with normal perfusion, an end tidal CO2 reading of less than 35 millimeters of mercury indicates hyperventilation. A reading of more than 45 suggests hypoventilation. In the patient with adequate circulation, the key uses for waveform capnography include the placement and monitoring of an advanced airway and the management of ventilation support. In cardiac arrest patients, waveform capnography reflects the effectiveness of chest compressions during CPR, and a sharp increase in end tidal CO2 signals the return of spontaneous circulation. The higher the end tidal CO2 pressure, the higher the cardiac output is during resuscitation. An end tidal CO2 of less than 10 millimeters of mercury suggests that the cardiac output is insufficient to achieve ROSC. If the CO2 readings are low during resuscitation, the team should optimize CPR quality by minimizing interruption in compressions, delivering compressions at a depth of at least 2 inches and at a rate of at least 100 but no more than 120 compressions per minute, allowing complete chest recoil and avoiding excessive ventilation. Sudden changes in the waveform should trigger immediate reassessment of the patient. When the waveform jumps up during resuscitation, this may indicate ROSC. A sudden drop in waveform of 20 points or more could indicate a sudden, severe decrease in cardiac output that might be caused by a pulmonary embolus, acute blood loss, or a life-threatening arrhythmia. A decrease to 0 indicates no gas exchange or no carbon dioxide delivery, such as occurs with a displaced endotracheal tube, or the sudden stopping of blood flow, such as occurs with ventricular fibrillation. A rising baseline in the end tidal CO2 waveform suggests that carbon dioxide is re-entering the side stream sampler during the inspiratory phase of ventilation. This reading might indicate that the patient is rebreathing carbon dioxide. This waveform has a prolonged phase 4, or inhalation, section. This suggests that there's air entering the trachea beyond the entryway that's being monitored. This happens if the cuff on the tube is deflated or if the tube is too small for the patient. In both arrest patients and post-cardiac arrest patients, ventilation and perfusion must be optimized to prevent lung injury, cerebral ischemia, and cardiogenic shock. The use of waveform capnography can dramatically enhance your ability to manage cardiopulmonary patients. Another type of CO2 detector, the colorimetric end tidal CO2 detector, simply changes color when it detects CO2. One additional confirmation device is the esophageal detector device, or EDD. The EDD is a bulb that providers compress and attach to the endotracheal tube. If the tube is in the esophagus, the bulb will not re-expand and fill with expired CO2. An alternative model is a large aspiration syringe attached to the tube. If the endotracheal tube is properly placed, providers will have no difficulty retracting the plunger. Esophageal placement will prevent plunger movement. Airway skills are fundamental to successful ACLS. Proper training, frequent practice and use, and logging both successes and complications can help build your skills and lead to more comprehensive, successful patient care.
Alright, let's resume now. Ayan. For sure, nakapag-break na po yung iba. And yung iba ay nanonood talaga ng video kasi kaka-break lang din. Sige po. So, we have tapos na po tayo guys sa ating sinus tachycardia. Tapos na tayo sa ating mga sinus problems. So, at this point in time, I'll be playing or I'll be showing you some of the DART simulator scenarios po. Based sa sa mga topics na na-discuss ko. Okay, let's try to analyze. So the heart rate here is basically 70. So guys, wala na yung mga 300, 150, 100 kasi this is a cardiac monitor. So nakalagay na po, naka-attach na, alam na po natin ang heart rate. Baka kasi yung iba, sir, bakit wala mga 300, 150? Kasi ayun hindi kasi to. 'Di ba? Yun kasi yung mga 300, 150, 100, nagagamit natin yan sa mga ECG paper po, sa mga strips natin. Pero pag naka-attach na sa cardiac monitor, automatic na po yan. So the heart rate is 70. The rhythm is regular. I can see P waves. They're clear and upright, followed by QRS, which is normal in nature. So therefore, guys, the patient here is experiencing NSR or normal sinus rhythm. Next. All right, the heart rate here is 38. So syempre pag less than 60 guys, it's automatic bradycardia. So the rhythm is regular. I can see P waves. They are clear and upright, followed by QRS, which is normal in nature. So therefore the patient here is experiencing sinus bradycardia. Next. The heart rate here is 120. The rhythm is regular. I can see P waves. They're clear and upright, followed by QRS, which is normal in nature. So therefore, the patient here is experiencing sinus tachycardia. Okay, next. The heart rate is 76, which is normal. However, guys, the rhythm is abnormal. So meaning the P waves also here, it's basically clear and upright, followed by QRS, which is normal in nature. The client is experiencing sinus arrhythmia. Okay po. Now, tapos na tayo sa sinus. Wala na akong utang doon. Let's now have the atrial tachycardia. Now, for the atrial tachycardia, sorry, hindi ko na-delete. And for the atrial tachycardia, it is actually expected, guys, na 150. Ayan, wait lang ha, i-admit ko lang si ma'am. Ayan. For, your atrial tachycardia, it is actually expected na 150 to 250 beats per minute. But are you aware, pag nag-duty na po sa hospital, usually 172 eh. The pathognomonic sign, for your atrial tachycardia is that, pag nag-170 ka, ang heart rate ni patient, tapos the rhythm is regular, however, the P waves are buried preceding to T wave. They are unclear. Meaning they are not clear because they are unclear, and they are buried preceding to T wave, then that's your atrial tachycardia. So again, ulitin ko. Pang heart rate mo, 150 to 250, the rhythm, walang problema po. However, the P waves here, they are buried. They are unclear. Napakita na po natin to kanina. Ayan. So for the atrial tachycardia, you're not sure ano to, sir? P or T? P or T? P or T? P or T, 'di ba? Pero pag sinus kasi ay ito T, ito P, ay clear pa, T, P. Ito hindi na siya clear. Kaya this one is unclear. So this one is the atrial tachycardia or the supraventricular tachycardia. Ayan, the supraventricular, ayan, ventricular tachycardia. Ayan, kasi doctors from Manila po, yeah, when we had the training with American Heart Association, sabi nga ng pinaka head namin, It should be pronounced as supraventricular tachycardia because ideally pala, the Supreme Court, dapat pala, it should be pronounced as Supreme Court, no? Hindi siya Supreme Court, but rather Supreme Court. So dapat it should be supraventricular tachycardia. When we had that training sa St. Luke, so lahat ng doctors nag-supraventricular tachycardia. It may sound awkward, pero yun, finalo lang namin sila. Na? So ayun din po, other term for your atrial tachycardia will be your the narrow complex tachycardia. Okay? Ayan, sige. So tapos na tayo sa atrial tachycardia, guys. Ano ba yung mga symptoms po natin dito para masabi natin akin na may atrial tachycardia ang isang tao? It can be asymptomatic, but very common kasi yung mga palpitations sa sobrang bilis ba naman ng pagtibok ng puso ni patient. There will be chest pressure, fluttering sensation in the chest. There will be dyspnea, no? There will be fatigue, the dizziness, syncope. Syncope is the medical term for fainting. Diba? Biglang may himatay ang patient po natin or na near na may himatay, that's the near syncope. Like grabe na yung mga dizziness ng patient natin. Now, the usual management, ipakita ko lang. Ayan. Only doctors are allowed to manage the said supraventricular, especially with the carotid sinus massage. Nurses are not allowed to perform this, but only the doctors po. They are allowed to massage the one lung o isang carotid artery. One carotid artery po for about 10 seconds. So here are the vagal maneuvers, guys. Kaya sila tinawag na vagal maneuvers is because they will tend to stimulate your vagus nerve. Diba? Once stimulated kasi yung vagus nerve po natin, ito yung gusto natin na effect eh. Diba? Tachycardia kasi si client. The effect of your vagus nerve stimulation, ayan, will be na magdi-decrease po ang heartbeat. So there will be bradycardia. So which is good, especially pag tachycardic ka. No? Papabagalin muna natin. No? I-bring back natin siya sa normal na heart rate. So coughing, yes. No? Coughing po, pwede yan, lalo na pag 50 years old and above. Pwedeng encourage ang client, ma'am. Pwede po tayong pwede po tayong umubo for 10 times or more. Ayan, kasi we are not allowed to massage a 50-year-old and above. Why? Kasi ang dami kasi nila mga fat deposits po sa kanilang neck. If you're going to massage that, baka ma-dislodge po yan. From thrombus, maging embolus, so causing stroke to your patient. Next, we have the squatting. Usually, nakikita natin ang squatting sa mga bata. Lalo na pag may mga tetralogy of Fallot. Or let's say may mga congenital disorders which are cyanotic in nature. Next, we have the breath holding is a form of what? A Valsalva maneuver din kasi yan. Next, na Valsalva kasi pag may itatae ka, if you're familiar sa tubol, hardened stool, iba kasi yung igit eh. Iba naman yung igit. Ang igit po ay utot na may sabit. Akala mo utot lang yon, pero trinidor ka, biglang may lumabas na. Naalala ko yan dati, Diyos ko po. Gusto ko sanang mautot sa bus na. Ang ganda kasi ng bus, 'di ba? From Manila going to Bicol. Sobrang ganda lang ng bus. Ano nga yung pinakamagandang bus? Guys, ano nga yung may basta pinakamaganda. Ano nga? Nakalimutan ko na tuloy yung mga bus nyo. Kasi kasi ako bigla akong nainis sa Bicol. Siyempre broken hearted ako, so ayun, nakalimutan ko na pati bus. Pero may good friend, syempre hindi ko makakalimutan yan. Yung isa lang talaga. Ayan, so we have the carotid sinus massage. Na i-massage mo lang yung carotid artery mo for 10 seconds. Now, anong itsura niya, sir? Ganito. So the doctor will try to auscultate muna. If that's pulsating, then therefore that's the carotid artery. And then pag okay, i-massage na po ng ating mga mahal na doctors. Okay, and that should be for 10 seconds. Guys, never po na sumobra, let's say, never po na dalawa ang i-massage mo, both carotid artery, grabe ka. Isang artery lang. Kasi pag both po, times 2 din na babagal ang puso, ang pagtibok ng puso. So baka mamatay din ang patient natin, guys. So delikado din po 'yon. So pwede po tayo mag-offer pala ng massage, lalo na sa ex po natin. Ex, gusto mo ba ng massage? 'Di ba? Para mamatay. Just. Carotid sinus massage na pala ang gagamitin nating massage sa kanila. Tapos excited pa sila, no? Sige, masahiin mo ako, no? Ayan. Next topic, guys, will be the atrial flutter or the atrial flutter. Now, the atrial flutter, guys, is commonly known as the irregularly irregular. Irregularly irregular. irregular. So when we say irregularly irregular, ayan, this is, ayan, sorry. Akala ko atrial fibrillation pa pala. Sorry, atrial fibrillation. Wait lang Atrial, ayan, fibrillation. Guys, sorry. Atrial fibrillation is the irregularly irregular. Ito yon, irregularly, ayan, irregular. Unahin ko muna tong masyadong irregular. Mamaya na yun si atrial flutter kasi mas na-differentiate kasi natin na. So, pag sinabi po natin atrial fibrillation, irregularly irregular. Alam niyo bang nakakatakot po ang atrial fibrillation? Why? These are the common causes of stroke. Ayan, it causes stroke kasi And as we all know, 'di ba, pag stroke, pag nagulay, ang patient po natin, stroke ang tawag doon. Now, dati po, in order for you to recognize na may stroke ang patient, we have this mnemonic known as you're the fast. However, binago nila. Nilagyan nila ng be fast. Ayan, these are the warning signs of stroke. Wait lang isulat ko lang si be fast. Letter B, letter E, F, A, S, and then we have letter T. Bakit daw siya be fast? Again, for you to recognize the warning signs of stroke, number 1, the balance. Ayan, there will be no balance at all. Ma-outbalance po ang patient natin, biglang matutumba. Next, we have here the eye. Ayan. So there will be a vision loss. Ayan, biglang parang wait lang, parang nabulag ang client, biglang dumilim ang paligid niya. Ayan, next we have your letter F, the facial droop. The facial droop biglang magsasag, biglang na-paralyze bigla. Iba naman kasi yung Bell's palsy sa stroke Although dati akala ko talaga na stroke ako, yun pala Bell's palsy, kaya I really thank God. Sabi ko, Diyos ko, end na ba to ng career ko? Na stroke na ba ako? Bell's palsy. Ayan, after Bell's palsy, bigla akong basta nag-numb na naman, no? Nag-carpal tunnel naman ako. Puro nerves ako Ayan, next we have the arm drifting. Guys, when we say arm drifting, biglang nawalan ng strength ang isang arm mo, biglang bumagsak. Okay, that's where the arm drifting. Next, we have the slurred speech. When we say slurred speech po, 'di ba? Sa states kasi, like let's say sa mga 911 tulad ng tito ko doon, and they usually ask the client or the patient to repeat. Now repeat after me. You can teach old dogs new tricks. Pag sinabi ng patient mo, you can teach old dogs to speak. Ayun, warning sign of stroke na 'yon. May slurred speech na kasi. Pero pag, ayan, sinabi ng patient, ma'am, please repeat after me. You can teach old dogs new tricks. Sabi ng client mo, you can teach old dogs new tricks. Bayot ang patient. Pero pag sinabi naman ng client mo, no, ma'am, repeat after me. You can teach old dogs new tricks. Sabi ng patient, you can teach old dogs new tricks. Guys, iba po ang ngongo sa taong na stroke. Okay po? I-clear ko lang yan. Kasi sometimes may mga stories kasi na na-diagnose ng stroke kasi daw may slurred speech. Ngongo lang pala si client. Kawawa naman, no? Binigyan ng mga warfarin, binigyan ng mga blood thinners, no? Kasi akala na stroke. Hindi po. Iba po ang ngongo sa na-stroke. Okay? Ayan. And lastly po, letter T, time to call 911. Okay? So it's time to call 911. So basically, pag may mga emergency kasi tayo, we usually dial these numbers, 911. Pero yung iba, baka iba ang idadial na number, yung hashtag 87000, Jollibee Delivery yon. Ibang emergency naman yun. Gusto ko yung mga emergency na pagkain, gano'n. Lalo na pag umabsent ka sa trabaho, di ba? Tapos galit yung friend mo, galit yung mga iniwan mo bigla sa ere. So magpapa-emergency ka na number, mga 87000, 'di ba? Suhol. Suhol ang tawag doon. So we have the word, okay, be fast. Okay po? Ayan. Again your atrial fibrillation sa sobrang, okay, grabe yung fibrillatory waves natin doon, pwede siyang mag-cause ng, ayan, yun ng, okay, stroke kay patient. So ang tawag natin, atrial fibrillation. Hindi po siya regular, sobrang irregular siya. Para siyang lagari na sobrang magulong lagari. Kasi meron tayong perfect na lagari At ito yon, the atrial flutter. When we say atrial flutter, guys, this is the perfect sawtooth. This is much more regular compared kanina. So we have here the perfect, ayan, the perfect sawtooth. Okay po. Ayan, so pag sinabi po nating perfect sawtooth, perfect na lagari po ito. It's much more regular compared sa ating atrial fibrillation kanina. Pwedeng umabot po ng 450 beats per minute. Kanina, sa atrial fibrillation, grabe yung mga ano doon, yung 'di ba, pag-eject ng heart kasi nag-aabot talaga ng 600. Ayan, so mas ano 'yun, mas worse talaga yung AFib po natin. So, ang technique ko lang dito, 'di ba? Atrial flare sounds like McFlare sa McDonald's. Ano bang itsura ng McDonald's, guys, 'di ba? Parang mga M, pero mas regular sila. Mas regular compared kanina na hindi po regular. Sobrang magulo. Pakitaan ko kayo ha. Ayan, kasi I'm about to end my atrial topics eh. Okay, wait lang. I-adjust ko lang yung ano, yung dart sims ko. Ayun. Naka-adjust na pala to, sorry. Okay. Ayan, the heart rate of the patient here is 176. Guys, pag mention mo pa lang ng 176, what comes in your mind ba? It's above 150. Tama po? If that's above 150, malamang atrial problem na to eh. Now, if that's 176, the rhythm here is regular. There's no problem with the regularity of the said rhythm. However, kasi the P wave here is buried. It's unclear. Okay po? If that is if that is unclear, guys, then mag-expect na tayo na unclear P wave to. So malamang atrial problem to. And then, take a look po sa kanyang QRS. It's narrowed. So therefore, the patient here is experiencing SVT or the supraventricular tachycardia, atrial tachycardia, or the narrow complex tachycardia. Next. Okay. Now, the heart rate here is 290. Guys, the rhythm here is what? Irregularly irregular. And I can see fibrillatory waves na ayan. So pag may nakita kang fibrillatory waves tapos the QRS is what? It's narrowed. Then, ang tawag dito it's the atrial atrial fibrillation. Okay po? O, di ba para siyang parang lagari, pero magulong lagari. May perfect kasi na lagari eh. Ito yung next, and that's the flutter or the flare. Okay, the heart rate here is 370. The rhythm is what? It's kind of regular as compared kanina, sobrang irregular. And then, I can see flutter waves. So pag may nakita kang flutter waves, perfect sawtooth na ang tawag dyan. So therefore, that's your what? The atrial, flutter po. Okay po? Ayan, so tapos na tayo sa mga atrial problems. Atrial tachycardia, wala na akong problema doon. Diba? Atrial fib, wala nang problema. Ayan, atrial fibrillation, atrial flutter, wala na po. Pero ibalik ko muna ang topics natin sa sinus. Ipapakita ko ang run-through ng ating mga rhythms po or ECG readings natin. And then try to answer kahit nasa bahay ka. All right, let's begin. So guys, this is your what? Normal sinus rhythm. Next. Okay, great. That's your sinus bradycardia. Next. That's your what? Sinus tachycardia. Great. Next. That is your what? Sinus
Arrhythmia.
arrhythmia. Yan. Great, great. Amazing si sir. Next. That's your what? Yung fresh na topic natin. It's your the SVT, the atrial tachycardia, yes, or the narrow complex tachycardia. Ayan. Tama ang mga sagot. No? So, nakikinig nga talaga sila. Next. Okay, ito yung magulo or irregularly irregular. That's your the atrial
Fibrillation.
atrial fibrillation. Galing. Next. So that's your what? Atrial flutter. Ayan. Or the perfect sawtooth. Ayan. Thank you, Sir Si Sir RV ba yun?
Yes, sir.
Okay. And may kasama ka bang bata, sir?
Opo, sir, yung anak ko kanina.
Akala ko, sabi ko, hala, bata na bang nakikinig ngayon ng ECG? Diyos ko po, ang talino naman ng batang yon. Ayan. Alright. Guys, sa lugar nyo ba, bumabalik na ba ang nursing? No? Kasi like bumabalik na po ang nursing ngayon. Kahit dito sa Davao City, like sobrang dami na ng mga nursing schools ulit. Parang bumalik yung 2006 na na parang feeling na sobrang yung like yung nursing lang talaga ang nagpapayaman sa school. Yeah, sobrang dami na po. Like grabe. Boom na naman ang nursing ngayon. Okay. Saan na ba tayo? Okay, let's now discuss. Okay, for a while lang ha. For a while lang. Ayan. Dito na tayo. We are now entering the ventricular problems. So, pag ventricular kasi, ang i-discuss natin, we have the ventricular tachycardia, monomorphic, and then we have the polymorphic, we have the VFib, asystole, and PEA. Ito yung mga i-discuss natin sa arrest setting. So let's discuss more of the monomorphic ventricular tachycardia. Guys, if that is monomorphic, mono meaning one form. O, tignan mo sa baba, isang itsura lang sila. Isang thumb, di ba? Kasi ventricular tachycardia kasi, it appears na parang swollen thumb. Yung thumb mo na swell, so ididikit-dikit mo yan, it's monomorphic kasi isang itsura. Now, with your monomorphic VTAC, guys, pag with pulse po, malamang automatic, pwedeng 101 to 250 beats per minute. Now, there's no P wave here. Sabi dito, usually not seen. So absent ang P wave. It's more of the QRS. And then it's widened in nature. Okay po? It's monomorphic VTAC. Kaya pag dikitin mo yung thumb mo, VTAC ang tawag doon. Monomorphic. Pero pag iba-iba ang itsura, sir, ang tawag doon, it's polymorphic ventricular tachycardia. Now, for polymorphic ventricular tachycardia, pwedeng may heart rate yan, pwedeng wala. Ayan. So we have the rhythm, may be irregular or basically chaotic in nature to. And then ganito ang itsura ng polymorphic. Guys, when we say polymorphic, this illustration actually depicts na the most common type, known as how do you pronounce this? This is actually a French term. Now, this French term po, ayan, that means what? Not twisted points. And how do you pronounce that? It should be pronounced as torsade de pois, since this is a French term. Now, your torsade de pois is brought about by a deficiency in the magnesium sa katawan po natin. So if ever kung meron kang hypomagnesemia, then expected po ang torsade de pois. Kaya nga ang drug of choice na in treating your torsade de pois will always be the magnesium sulfate via IV. Okay po? Ayan. So again, in polymorphic VTAC, pag nakita mo parang tinwist, kasi twisted points kasi, kaya nga torsade de pois yan eh. So parang tinwist, parang party streamer sa ating computer, diba? Pag chew, tapos biglang nagro-rotate bigla, parang tinwist. Yeah, it's polymorphic ventricular tachycardia in multi-form, kaya siya it's poly. Is it dangerous? Of course. Mas delikado po ang ang polymorphic kesa sa monomorphic ventricular tachycardia. Pero pareha silang delikado. Ventricular problems na kasi eh. Ventricular problems, or what, no, are said to be dangerous, no, nakakatakot, no, ang mga rhythms na to. So we have examples na of polymorphic ventricular tachycardia, pero itong torsade po talaga ang pinaka-common. Itong Brugada syndrome, yes, it's common also. Sorry, it's not common. Kasi ito yung mga stroke na nangyayari po na less than 18 years old. Kaya nga 'di ba, ito honestly nung hindi pa ako estudyante no ng let's say na sa medical, narinig ko lang to sa parang report ata. I'm not sure if that's KMJS na pero diniscuss kasi doon si Brugada syndrome. And then na-open up ako, sabi ko, ang ganda pala no pag nasa medical field ka. So itong si Brugada, hindi ko talaga siya makakalimutan. Siya yung eye-opener sa akin. Sabi ko, okay, I need to choose this profession na para at least, 'di ba? May alam na ako, no? Na ito pala yung stroke na nangyayari po sa sa mga halos less than 18 years old. Mga teenage years. Kasi 'di ba ang stroke kasi nangyayari naman kasi yan sa mga adults eh. Hindi masyado siya common sa teenagers, like less than 18 years old. Na ayan, sige. Now, let's discuss your another cardiac arrest po known as the VFib. Ayan, pag sinabi po natin nag-VFib si patient, guys, malamang sa malamang na this is actually a sudden cardiac death experience. A sudden cardiac death experience. Ito na yung mga times na nagko-code blue na po tayo. Code blue to ER bed 1, code blue to ER bed 1. When we say code blue, that means a cardiopulmonary, 'di ba? Arrest kay patient. So pag may cardiopulmonary arrest, there should be cardiopulmonary resuscitation. Okay po? Now, when we say VFib kasi, na ventricular fibrillation. Again, tinanong ko na kanina kung anong unahin. Pag may VFib, is it defibrillate? What? High quality CPR. The answer is high quality CPR. Kasi it takes time pa po na para mag-defibrillate, 'di ba? Ang dami pa nating mga spills na please charge the patient to what? To 200 joules. Okay, doc, charging the patient to 200 joules. Please clear the patient. Paddles on chest. 1, I'm clear. 2, you're clear. 3, everybody clear. Clear. Shocking, shocks delivered. See? Ang dami pa kasing sinasabi. Why not you start with your high quality chest compression while preparing? Okay? While preparing po. All right? Kasi minsan naka-focus na lang tayo sa machine. Guys, free lang po mag high quality chest compression. Available po always. Anytime ang mga kamay po natin. Yes, I know they are shockable. Pero don't forget, shockable kasi kailangan din niya ng early compression. After early compression, i-combine na po natin si early defibrillation din. Okay po ba? Now, para sabihin po na ventricular fibrillation yan, the heart rate is 0. Arrest kasi eh. The rhythm here is chaotic, na? So ganito, para talaga siyang worm, na? So there is no P-wave, no QRS. So ang tawag natin, ventricular fibrillation. Now, just so you know also, ventricular fibrillation has 2 types. Number 1, we have the coarse or the bigger ones. And then we have the fine or the smaller ones. Naalala ko tong smaller ones. I-share ko lang ha. I have a friend na tapos here comes na parang napagalitan siya ng doktor. Napagalitan lang talaga siya, like sobra siyang napagalitan. Kasi ganito ang nangyari. Sorry ha. This is based on my experience. Based on my experience. Although we have doctors here, pero this is just based on my experience. Bale, ganito ang nangyari kasi. So, sa province kasi nangyari yan. So, ganito na. So, sabi lang kasi na ayun na, nag-asystole daw. So, syempre, di ba guys, pag asystole, there should be no defibrillation. Asystole kasi, the purpose kasi of defibrillation po is for you to stun the heart, na para yung irregular ay magiging regular. So ayun, so asystole. Akala namin asystole. Sige, so no defibrillation. Nagulat kami, but parang hindi pa rin okay ang client. Hindi pala na Zoom, no? Kasi wala din kasing utos coming from the kataas-taas or galing kay Doc na na i-maximize 5 to 10 times. So alam niyo ba kung anong nangyari, guys? Min-maximize ng friend ko, no? So pag maximize niya, ayun, nakita namin na hindi pala siya asystole but rather fine ventricular fibrillation. So, siya, sabi niya, although pasimple lang naman kasi talaga yon honestly. Doc, nag-Zoom po kami kanina. Hindi po siya asystole, but rather fine ventricular fibrillation. So si toxic na doc, pinagalitan talaga siya sa harap-harap na. So parang, ngayon lang? Bakit ngayon lang to nangyari? Ba't hindi nyo zinom? Ganon. So parang, okay, sige. Na. So ayun guys, ang nangyari, alam niyo ba kung anong nangyari? Na-hurt talaga yung friend ko. Sabi niya, magdo-doktor ako. So ayun, nag-doktor siya. Na. And yeah, top-notcher po siya, top 2 na kaya proud na proud ako sa kanya. Ayun, kaya from time to time nakikita-kita kami always. Kasi iba-iba kaming field eh. Siya kasi syempre doktor. Ako naman more of lecturer like sa NLE, sa nurse licensure examination, sa NCLEX, sa training, and then nagpo-full-time din ako na clinical instructor ngayon, handling 4th year and 3rd year. Ayan, so ayun po. Kaya ayun, na-happy ako, kasi that experience humbled us, and ayun, iba yung iba yung basta pag-atake niya, nag-doktor din talaga siya agad. Sabi niya, yeah, grabe yung experience na yun. Siguro ako din kasi dati gusto ko talaga maging doktor din. Kaya idol na idol ko yung mga doctors po natin. Kaso when I took the board examination, naging reviewer na ako agad ng nursing. So per hour na ang bayad. So nag-iba na po ang ang ambisyon ko sa buhay. Ito na lang po ay ang magiging kabit ng doktor. At least hindi na ako mag-aaral. Nakala ko din talaga na yung doktor na consultant na jowa ko sa sa Legazpi. Akala ko din forever na kaso wala pala talagang forever. Tapos kasi timing din kasi yun yung first na lockdown. Naalala niyo yung lockdown? Like, na-appreciate ko talaga sa Legazpi. Legazpi kasi yun eh. Tapos, ayun, As in like, grabe ang ang mga priority natin, priority lane for the frontliners. As in like, grabe, Parang, parang mga God and goddesses tayo sa mga grocery store, sa mga malls. Kasi tayo lang nakakagala, Na-appreciate ko dyan sa Legazpi. Siguro, okay naman ako eh, naka-move on naman ako. So if ever kung babalik man ako ng Legazpi, punta talaga ako ng Sorsogon. Punta talaga ako doon sa sa haba. Doc, alam mo na, Doc Melchor, alam mo na yung place na yon?
Ay, alin po?
Alam mo na yung place na yon sa Sorsogon? Naalala mo na?
Hindi ko maalala.
Kalimutan ko eh. Basta ang sabi
Search
ko,
ko.
where villas meet mountains. Tapos 'di ba may villa, tapos may mga pool, ganun. Ay tanungin natin si Doc Adel. Doc Adel, alam mo yung sa Sorsogon po, yung magandang doon, yung may mga ang tawag doon, basta may mga villas na may mga pool talaga. Parang feeling ko nasa parang nasa Bali. Basta sobrang ganda lang. Diyos ko, gusto ko talagang bumalik doon. Gusto ko mag-land trip from Davao to Sorsogon.
Hindi ba yun yung Residencia del Hamor?
Ayan.
Yan,
Ayan,
Doc.
yun.
Feeling ko si Doc Ojeda always siya nandun eh. Yes, Doc Del Hamor. Oy.
Yeah,
Doon
maganda
kasi Doc, doon kasi ako dinala ng ex ko, Doc, na consultant ng BRT.
Exclusive kasi yung lugar.
Yes, Doc. Ako, parang sabi ko, ang ganda. Kasi siya eh, parang kahapon, parang yung Facebook ko na parang, parang parang 1 year na ata or 2 years, parang ganun. Tas basta, ang ganda lang talaga doon. Hindi naman masyado siya mahal. Although nasabi ko na hindi mahal kasi hindi naman ako nagbayad eh.
Okay. Pero mahal.
Yes, Doc. Feeling ko, Doc, mahal. Nasa 15 ata. Yeah, parang ganon. Mga 15 something. So, ang nilibre ko na lang sa kanya is breakfast. Tapos ang in-order ko yung pinaka-cheap.
Okay.
Ayun, Doc. Consultant ka na din, Doc? Doc Adel?
Di naman ako ganun ka-big time.
Ayan, ang importante, Doc, may-ari ka na ng hospital.
Okay.
Yeah, nice to meet you, Doc. Na-happy ako pag may mga nurses and doctors, ayan, na from Bicol. Sobra akong na-happy. Ayan. Sige po.
Okay.
Thank you, Doc. So we have our asystole, guys. Ayan, when we say asystole kasi, pag nasa ER tayo, it's flatline. No? Pero pag nasa OR tayo, ang term nila will be the cardiac standstill. Now, what are the protocols para masabi po natin asystole? Number 1, no, for the assist. Ayan, asystole. Ayan, for the asystole number 1, we always check no, for the pulse of the patient. Aside from checking for the pulse, we check for ECG leads. Ayan, for ECG leads. Ayan, and then lastly, we need to maximize ECG 5 to 10 times in order for us, no, para masabi talaga natin na nag-asystole ang client. So therefore, ganito. Before po natin sasabihin sa ating mga mahal na doktor na nag-asystole si client, we always check for the pulse. So magka-count tayo, 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. There is no pulse. Guys, ganun po mag-check ng pulse. It should be 1, 1,000, 2, 1,000. Ang Red Cross kasi, ganito po magturo ang Red Cross. 1, 1,001, 1, 1,002. Mali yun. It should be 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. Hanggang 5, 1,000 pwede na po. Although ang counting kasi dapat, it should be not more than 10 seconds. So kahit 5 seconds, okay na. Ang importante, di ba, ASAP, mabigay na po natin ang kailangan ng client. Now, if ayaw mo ng 1, 1,000, pwede naman po ang Mississippi. Ganito mag-count. 1 Mississippi, 2 Mississippi, 3 Mississippi, 4 Mississippi, 5 Mississippi. The patient has no pulse. However kasi, may mga issues kasi ang mga counting. Lalo na pag naguluhan ka sa counting, na yung 1, 1,000, yung iba ganito mag-count, 1, 1,000, 2 for 1,000, 3 for 1,000. Nasa Lazada yan. Shopee sale yon. Yung mga 2 for 1,000 na yan. And then yung iba din, no, na mga bulol, 'di ba? Yung Mississippi, Diyos ko, ganito mag-count. 1 Mississippi, 2 Mississippi, 3 Mississippi. Ayan, so si patient din natawa. Nabuhay na lang tuloy ang patient nang wala kang nagagawa. Ayan, so again, for the asystole, guys, you check for pulse, you check for ECG leads. Sasabihin mo kay Doc, all ECG leads are in place. Then, ayan, maximize 5 to 10 times. Doc, I already maximized, the ECG 5 to 10 times. And it's confirmed po na asystole. Okay? Ayan, now, for the asystole kasi, ayan, so we have a flat line, na? Flat line na kasi yan eh. That's the asystole. Guys, question. Ayan, when we say asystole, is it a shockable or a non-shockable rhythm? Anyone from the group? Shockable or non-shockable? Kasi dalawa kasi yan eh. We have the shockable and then we have the shockable in nature. Pag shockable kasi dalawa, very common po. Number 1, we have the VFib or ventricular fibrillation. And then next, we have the pulseless VTAC. The pulseless ventricular tachycardia. Guys, you need to make sure na it's pulseless para masabi mo na shockable. Meaning to say, before mo isha-shock din, though alam natin na isha-shock talaga, before mo i-shock, why not mag-start ka rin ng high quality chest compression? Because early CPR plus your early defibrillation, ito yung kailangan ng shockable rhythms natin. How about pag non-shockable? Now, for the non-shockable naman po, dalawa din, very common. Number 1, we have the asystole. Next to asystole, we have the PA or the pulseless. It's your pulseless electrical. Ayan, pulseless electrical activity. Now, when we say asystole and then pulseless electrical activity, guys, arrest pa rin ang patient natin. And they are both pulseless in nature. Actually, itong mga shockable, pulseless din eh. Itong non-shockable, pulseless din. It's just that, sa shockable, bakit siya kailangang i-shock? Kasi irregular kasi ang rhythm dyan. May PQRST na irregular eh. Na may rhythm ka tas irregular. You need to stun the heart. Gugulatin mo ang heart para ma-regular siya. Ito namang sa non-shockable, number 1, walang pulso. And then wala din siyang PQRST. Flat. Itong PA, meron man siyang PQRST pero it's an artifact. Wala lang din yung mga PQRST niya. Kaya ang pinaka-importante dito sa non-shockable is that you need to compress the client, but there should be no defibrillation because defibrillation is useless. And then diretso po tayo sa drug of choice. Okay po? Now, itong PA, madidiscuss ko siya later. Ayan. So we have the asystole. Dalawa kasi yung asystole natin. We have the plain asystole, ayan, flatline. Or pwede rin tayong may P-wave asystole. Guys, you need to maximize if that's asystole. Why? Kasi pag maximize mo, pag ganyan, okay lang, flatline talaga. Pero what if, pag maximize mo, sir, bakit parang may mga fine fibrillatory waves? Ayun na po. Guys, pag may fine fibrillatory waves, iba na po ang protocol natin. Asystole is a non-shockable. Bakit may fine ventricular fibrillation? So you need to change the algorithm. You need to change the mega code from asystole into fine ventricular fibrillation. Did you get me? Ayan. Sige po. So we are done with the asystole, P-wave asystole. Bakit siya P-wave? Kasi P-wave, may P-wave kang nakikita. Ayan. Only si P-wave lang nakikita po natin. Now, let's discuss pulseless electrical activity. For a while. I-admit ko lang si ma'am. Ayan. For the pulseless electrical, wait lang. May naririnig ba kayong guys? Sounds? May narinig kayong sounds? Wala.
Yung voice mo lang, sir.
Okay. Walang sound kasi may party kasi dito sa likod eh. Sorry.
Wala naman, sir.
Wala naman, sir. Ayan. Kasi min-maximize, on the maximum level na kasi ang nito, yung mga noises, dapat hindi siya maririnig. Okay, so we have the pulseless electrical activity. Now, pag sinabi po natin pulseless electrical activity, series of arrests kasi to, tapos biglang nagkaroon ng PQRST ang patient. Meaning to say, si patient nag-arrive na sa tinatawag na, let's say sa ER, may sinus bradycardia. From sinus bradycardia po, biglang nagkaroon ng VFib or ventricular fibrillation si patient. From VFib, guys, biglang nagkaroon ng asystole, tapos nagulat ka, bakit may PQRST si patient? So ikaw mismo, wait lang, parang confused ako Parang diskumpiyado din ako and parang hindi ako sure. No? Kung buhay na ba talaga ang patient ko. So sasabihin ng doktor, okay, Mr. Adlawan, you check for the pulse. 1,000, 2,000, 3,1,000, 4,1,000, 5,1,000. Guys, ang ganitong tracing, wala palang pulso. Ang tawag doon, pag negative pulse tapos may PQRST na, it's the pulseless electrical activity. From the word itself, pulseless. Ang nakikita po natin na PQRST, they are just merely an artifact. Na artifact lang mga yan. So meaning, patay pa rin ang patient natin. On an arrest pa rin si patient natin. Okay po? Ayan. So again, ang pinaka-importante dito, if that is a non-shockable, early compression, plus your early drug administration. Yun yung pinaka-importante. Pero pag shockable rhythms naman, kailangan ng what? Ng early compression plus your early defibrillation. Okay po? Ngayon, may naririnig na kayo guys or wala pa rin? Kasi parang ako pa lang naiingayan eh.
Wala naman, sir. Sa akin, sir, wala po.
Wala, no? Yeah. Pero parang feeling ko naririnig nyo kasi sobrang ingay dito. Ayan, so effective nga yung yung maximum dapat na noise cancellation. Okay. Sige. So at this point in time, ayan, magdi-discuss na tayo ng ECG pharmacology na po. Okay? Guys, may mga work pa ba kayo mamayang hapon? Kasi honestly, pwede po natin siyang tapusin up to 12 o'clock. May mga work pa ba kayo or wala? Yung iba wala naman siguro, no? Sige. So let's discuss na po the ECG pharma. Pharma na po tayo. Now, when we say pharma kasi, ayan, no, magdi-discuss tayo ng mga medications, let's say sa pre-arrest. So guys, we have the pre-arrest, we have the arrest, and then we have here the post. Ayan, arrest setting po. Now, pag sinabi po nating pre-arrest setting, ayan, tatlo po yung ititreat natin. Number one, we have the sinus bradycardia. Sinus bradycardia. Next to sinus bradycardia, we have the SVT. Next, we have the VTAC, and this one is with pulse. Next, pag arrest naman po, meaning hindi mo na nakakausap ang patient natin, ano ba usually ang tinitreat natin dito pag arrest po? Number one, we have the VFib. Next, we have the pulseless, VTAC. Next, we have the asystole. And next, we have the PA. Ayan. So ito po yung mga tinitreat natin. Pre, and then we have the arrest setting. Wait lang ha. Pagalitan ko lang. Sobrang ingay kasi. Wag na nga lang. Makabarilin pa ako ng kapitbahay ko. Instructor, binaril dahil naingayan sa Zoom. Basta ang importante, hindi niya naririnig ha. Ako kasi sobrang rinig ko talaga dito eh. Parang nagko-concert na sila. Ngayon pa lang. Sure ha, walang naririnig. O, tanungin ko nga si Ma'am Karen. Ma'am Karen, may naririnig ka
Wala
ba?
naman po, sir. Wala po.
Ako kasi ang naiingayan talaga dito eh. Siguro dahil siguro kasi dahil maingay ako kaya nag-ingay din siya.
Wala naman, sir.
Wala. Ito si Doc Melchor. Doc Melchor, mag-on ka nga ng camera kasi nakita ko si Doc kanina, ang gwapo eh. Doc Melchor, may naririnig ka ba?
Ano po?
May naririnig ka bang ingay dito? Wala.
Wala po.
Wala. Naka-off ata yung camera mo.
Ay, lumipat kasi ako sa laptop. Di ako marunong.
Hindi, i-click mo lang yung ano, yung parang may video dyan.
Ay, naka-click na po.
Ba't parang
Oo.
ano lang? Ba't
Black.
parang black lang siya? Baka nasira siguro yung laptop mo, sir.
Ayusin ko po mamaya.
Doc, ilang taon ka na, Doc?
28 po.
Bata pa. Bata pa si Doc. Ayan. So we have the pre and then we have the arrest. Now, let's try to treat na po the pre-arrest setting. Guys, ganito. Pre-arrest and then we have the arrest and then we have the post-arrest. Ang pre kasi, before siya nag-arrest. Tama po? At pag nag-before siya nag-arrest, kausap mo pa ang patient dyan. So I'll give you a scenario. Arriving at the emergency department is a 75-year-old male patient whose name is Mr. Fernandez. Mr. Fernandez is a cold chlamydia-diaphoretic patient on ER bed 1. Approach your patient now. So ito na. Good morning, Mr. Fernandez. I am Mark Adlawan, your most responsible nurse. How are you feeling today? Sabi ni Mr. Fernandez, I don't feel like talking to you, Mr. Adlawan. I feel like I'm dying and I'm not in the mood. Okay, Mr. Fernandez, you are upset. But before that, let me check your vital signs first. Nag-check ka na ng vital signs, guys. In-attach mo na ang patient tapos may sinus bradycardia ang patient. Ayan. 2 patients, okay, suffering from sinus. Ayan, Brady. Ayan, cardia po. Ano ba ang gagawin natin? For patients suffering from sinus bradycardia, you're going to check the BP of the patient. Why? We need to know kasi whether if it's stable or unstable. Alam niyo ba, American Heart Association recommends that if that's greater than, okay, 90/60, Diyos ko po, ang ingay nila. This means stable. Ayan, stable yan. Pero pag less than po, 90/60, ang tawag, tapos ang kanta pa ngayon guys, baby ko si kulot. Let's yung kanta na yan. We have your stable. Pag greater than, tapos pag less than, we have your unstable. Now, sinus bradycardia with a stable muna tayo. So upon checking the patient's BP, it's greater than, okay, 90/60. Ayan, 60. If that is 90/60, guys, alam niyo ba stable to? And if that is stable, ayan, syempre, you need to observe. I-observe lang po natin, wala tayong ibang gagawin but rather observe lang. However kasi, upon checking the patient's BP, it's less than, okay, 90/60. Alam niyo ba pag less than 90/60, ang tawag natin doon unstable. And if that is, okay, unstable, you need to manage the client. Ayan, so there should be, okay, management dapat. So you need to manage. Now, sir, ano ba ang management natin? So you need to manage, ayan, known as your, okay, the ATDE. Management. Ayan, manage. Ayan, meant po. So we have the mnemonic ATDE. Sir, bakit may ATDE na mnemonic? Letter A, letter T, letter D, and then we have your letter E as our mnemonic. Now, sige nga, sabay-sabay tayo, guys. Everybody say ATDE. Ayan, thank you. Ayan, pag sinabi po nating ATDE, letter A for atropine sulfate. Now, for the atropine sulfate, it should be 0.5 milligram times 6 doses with maximum dose of 3 milligrams Maximum dose of 3 milligrams given every 3 to 5. Ayan, minutes po. So again, first drug will be atropine sulfate at 0.5 milligram times 6 doses with a maximum dose, okay, of 3 milligrams given every 3 to 5 minutes. The next po will be the transcutaneous spacing. Okay, so we have the transcutaneous spacing po. Now, aside from transcutaneous spacing, guys, we have our letter D and then we have our letter E para makompleto ang ATD. Letter D stands for the dopamine. And then letter E for epinephrine. Now, for the dopamine po, ganito guys. Dopamine ha, tatlo kasi ang doses nito eh. We have the renal dose, we have the cardiac dose, and then we have the vasopressor dose. Now, when we say renal dose, ayan, ano ba ang renal dose natin? It's 2 microgram per kilogram per minute. Cardiac dose po is 5 microgram per kilogram per minute. Next, we have the vasopressor dose of 10 microgram per kilogram per minute. Guys, ano bang ibig sabihin ng renal? Kung gusto mong paihiin ang patient, you give the renal dose. Pero kung gusto mo, okay, pataasin ang kanyang heart rate, and then you give the cardiac dose. If your focus is the BP of the patient, you give the vasopressor dose. Ulitin ko ha, kung ihi ang gusto mo, renal dose. Kung increase heart rate ang gusto mo, cardiac dose. And kung gusto mong increase ang BP ng patient, it should be the vasopressor dose. Kaya nga, vaso VP. BP, di ba? Blood pressure. Again, so these are the dopamine, okay, doses po natin. However, kasi, papipiliin kita, anong ibibigay mo kay client? Renal, cardiac, or vasopressor? Guys, you focus on the problem. Malamang, magbigay ka ng cardiac. Kasi bradycardic ang patient mo. Huwag kang magbigay ng renal. Mababa na nga ang BP, unstable na nga si client, paihiin mo pa, mas lalong mamamatay ang patient. Or pwede ka rin magbigay ng vasopressor, depende sa'yo. Na kung gusto mo talaga ang focus is the BP, so be it. Pero kasi the problem here, may sinus bradycardia ang patient. So focus on the cardiac muna tayo, which is the cardiac dose. Diniscuss ko lang si renal, diniscuss ko lang cardiac at vasopressor just to have a review lang po. Now, we have the epinephrine. Epinephrine, we have the initial dose, and then we have the maximum dose. The initial dose for epinephrine, guys, will be your 2 microgram per minute. Now, for the maximum dose, we have the 10 microgram, ayan, per minute po. So we are done na po sa ating mnemonic na ATD. And that's for the sinus bradycardia. Letter A for atropine, letter T for transcutaneous spacing, letter D for dopamine, and then we have a letter E for epinephrine. Guys, isa-isa lang. Huwag po silang isabay na ibigay kay client po. Alright? Now, tapos na tayo sa sinus bradycardia. Our next topic will be the SVT or the supraventricular tachycardia, known as the atrial tachycardia, or commonly known as the narrow complex. Ayan, the narrow complex tachycardia po. Now, for the SVT, we always check for the BP. Now, what if the BP is greater than 90/60? Ang tawag doon, it's stable. Guys, if that is stable, then all you need to do is that we need to have the 2Ps dapat. Ano yung 2Ps po natin? Letter P stands for the physiologic management. Next, letter P for pharmacologic. So pag pharmacologic, we're going to give drugs. For physiologic, guys, you can perform the carotid sinus massage. But again, if doctor ka, it should be the carotid sinus massage. Magmamassage ka lang ng carotid artery for 10 seconds. Again, intended for doctors only. Guys, scenario, if the patient is 50 years old, do not attempt to massage the carotid artery. But instead of massaging, okay, why not encourage the patient to cough for more than 10 times? Next, we have the pharmacologic. When we say pharmacologic, we don't use it's of course pharma, di ba? We use drugs rather. Now we use drugs here or medication. Now the only way to improve this, syempre pharmacologic. So we need to make use of your medication such as ang pinaka-common na medication, guys, of course we have the adenosine. Alam niyo bang adenosine, there should be a rapid IV push here. Rapid IV push. That rapid IV push should be 1 to 3 seconds na IV push. Why? Because the half-life of your adenosine is only 10 seconds. If the half-life is only 10 seconds, then, okay, delikado nga to. Kasi pag 10 seconds po, 50% na lang ang effectivity ng drug po natin. So therefore, para gumana talaga siya 100% at hindi 50%, you need to rapidly IV push that one for about 1 to 3 seconds. Now, if you're going to ask me what are the doses, the doses rather, for the doses po, we have the first dose, we have the second dose, and then we have the third dose. For the first dose po, we have the 6 milligram, 12 milligram for the second dose, and then 12 milligram for the third dose. Kaya ang technique ko dito, it's your 6, 12, 12. Kaya when I took the board examination, sabi ko, adenosine, adeno 6. Bakit adeno 6? It's 6, 12, and then 12. And then usually given every 1 to 2 minutes po ito. Alam niyo ba, 1 to 2 minutes po yan, hindi 12 minutes. It's 1 to 2 minutes. Alam niyo ba sa first dose pa lang, bababa na po no, ang heartbeat ng client. Diba, this is atrial tachycardia, so 170. So biglang bababa yan. I've witnessed a video po sa Facebook na pina-perform po sila ng isang doktor sa ER doctor po siya. Pina-blow lang siya ng syringe. Syempre walang needle. Pag blow niya, it's a form of Valsalva maneuver kasi, 'di ba? You're going to bear down. Pag blow niya, makikita mo sa screen, 'di ba, pababa ang heart rate ng patient. Amazing, no? Yeah, it's part of the physiologic, not pharmacologic therapy for SVT or atrial tachycardia. Nag-blow lang siya ng syringe na walang needle. So ganito ang itsura niya sa ER bed. Nakaupo, tapos pinablow. Tapos pag blow niya, biglang tinaas ang kanyang mga paa facing sa wall, sa ceiling rather, pero naka-blow pa rin. No, from 170, biglang nag 165, nag 145, tapos nag 120 hanggang sa nag 70, tapos pinastop ng doktor. Amazing, na? Amazing 'yon. Pinablow lang. It's a form of Valsalva. 'Di ba, vagus nerve, okay, stimulation po. Okay? Now, tapos na po tayo na sa ating sa ating stable. What if SVT unstable? Ayan. Kasi less than 90/60 ang kanyang BP. Anong gagawin daw? Ayan, ni doctor. Siyempre si doc ay may letter S yan. Or si team leader. Ayan. Number 1, we need to sedate the patient. I-sedate mo lang ang patient. Okay, we sedate the patient using mga diazepam, midazolam, we have the propofol, and then we have the etomidate. Okay po? Diazepam, midazolam, propofol, and etomidate. Ito yung mga pang-sedate po natin kay patient. Pero wag mong ibigay utang na loob lahat ng to. Tulog po ang patient mo for life, na. So we have the diazepam, ayan, which is very common. Propofol, although propofol kasi ginagamit to pang sedate during intubation. Yeah, very common to. Etomidate is not common here in the Philippines, only in the States. And alam niyo ba, propofol po, ito po yung in-abuse ni Michael Jackson. I guess na sa mga parang, if I can vividly recall, it was 7 to 8 gallons na of propofol ang na-discover sa kanya upon autopsy. Naalala ko yung word na autopsy. I have a patient before. Sabi ko, good morning Miss Solis, kamusta po? Tapos parang siyang sabog. Sabi pa niya, okay lang Mr. Adlawan, I just had my autopsy. Sabi ko, ha? Sure, autopsy? Sure na ba talaga na autopsy ka? Sabi ko, sure ma'am, autopsy? Sabi niya, sure ako na in-autopsy ako. Kasi baka daw kasi may cancer. Sabi ko, autopsy. Sure? Hindi biopsy? Sabi niya, oo. Yeah, parang ganon. Sounds like, nakikipag-safe answer pa siya. Yeah. Siguro nasabog lang siguro sa anesthesia, guys. Ewan ko sa kanya. Iba po ang autopsy sa biopsy, Ikaw ba naman hiwa-hiwain yung brain mo, yung heart mo, tapos buhay ka pati? So we have your letter S. Now, Sir, after letter S guys, na syempre sedate na. Sinesedate po natin ang patient, lalo na pagpangit. Na? Pero pag gwapo, you seduce the patient. Yes. Or pag maganda, you seduce them. Pag pangit, sedate na lang po. Ayan, pero sabi nga nila, wag choosy pag hindi yummy. We have our letter S, we have the synchronized cardioversion. So we have the synchronized, ayan, cardio, ayan, version po. When we say synchronized cardioversion, kukuryentihin po natin ang patient. Kaso, kaya siya tinawag na synchronized. The usual kasi, let's say si unconscious patient, no, kinuryente mo, unsynchronized yon. Pero pag ikaw na conscious guys, kukuryentihin kita, di ba ma-IR ako? So before kita kukuryentihin, papututulugin muna kita. Kaya ang tawag doon, synchronized cardioversion. Defibrillator pa rin kasi ang gamit mo dito eh. It's just that patutulugin kita, sasadyain kong patutulugin kita para ma-reorganize natin ang inyong heartbeats. Okay? Ayan, take note, nag-SVT ang patient. No? Ayan, so we have the synchronized cardioversion charging at SVT sounds like 50 joules. 50 joules lang po tayo ha. Ayan. Guys, okay lang bang isagad ko na to up to 12 o'clock? Isagad ko na up to 12 o'clock ha. Ayan, sige.
Sige po,
So
sir.
okay lang ba?
Okay lang sa akin, sir. Ewan ko lang po sa mga kasama.
Yeah, isagad
Okay
na lang
lang
po.
din po sa akin, sir.
Yes, isagad na natin up to 12 o'clock. Kasi patapos naman na tayo eh. Okay po?
Okay po.
Sige lang.
12 o'clock tapos na po tayo. Usually kasi our second day is intended for, ayan, half ng phlebo tapos half ng ACLS na. Ayan, and then, ayun po, nag-start naman kasi tayo ng 8 o'clock at hindi po mga 9 o'clock. No? Start kasi tayo kanina ng exacto sa oras po, or exactong oras. Alright, we are done na po with SVT. Next, we have the VTAC, ventricular tachycardia with pulse. Again guys, ang VTAC na to ay may pulse, kaya under pa rin tayo sa pre-arrest. Meaning kausap pa ang patient, may pulso eh. Iba kasi ang VTAC na walang pulso mamaya. Okay po? So hindi lahat ng VTAC ay automatic unconscious si patient. May mga nag-VTAC na nagte-text. May mga VTAC na kinakausap ang watcher, no? May nag-VTAC na kinakausap no ang nurse, 'di ba? Habang nagva-vital signs. Kaya you need to watch out. Pre-arrest setting 'yan. Kasi from VTAC with pulse, pwedeng magkaroon ng VTAC na walang pulse later, boom, arrest setting na 'yon. When we say VTAC with pulse, of course, let's check again the BP of the patient to know whether if it's stable or unstable. Upon checking the patient's BP, guys, it's greater than 90/60. So malamang this one is stable. If this one is stable, then anong gagawin po natin? 2 P's pa rin tayo. First P, you need to call the attention of the doctor. So physician consultation tayo. Physician, ayan, consultation. Ayan, so tawagin natin si Doc. Doc, we have this patient, Doc, suffering from ventricular tachycardia but with pulse naman, Doc. Ayan, sige. Ayan, sige Mark, na bigyan mo bigyan mo ng drug yan, na? So we have the pharmacologic. Ayan, so Doc, okay po. So anong ibibigay po natin, Doc? We have the amiodarone. Ayan, we have the dose of 150 milligram over 10 minutes. Ayan, guys, are you aware that amiodarone is a class 3 anti-arrhythmic drug? So it blocks the sodium, the potassium, and then the calcium channels. Sodium, potassium, and calcium channels po. Again, ayan, ano ang dose natin? It should be 150 milligram over 10 minutes. Sir, bakit 150 lang? Hindi pa naman kasi nag-arrest eh. Kasi pag naging pulseless na po yan, ang 150 magiging times 2, which is the original one, magiging 300 milligram over 10 minutes. Again, amiodarone is a class 3 antiarrhythmic drug. It blocks sodium, potassium, and calcium channels. Okay po? Now, we are done na sa ating VTAC with pulse. However, what if 90, less than 90/60? Ang tawag natin doon, it's unstable. So we have an unstable ventricular tachycardia, with pulse. Ano ang gagawin natin? 2 S's pa rin po. The same pa rin, guys. First S, we need to sedate the patient. Gamit yung mga binigay po natin kanina. Either diazepam, midazolam, propofol, etomidate. As long as it's available, diazepam kasi talagang binibigay eh. Now, sir, synchronized cardioversion. Ayan, mas mataas-taas po pag nag-VTAC si patient, 100 joules. Kanina 'di ba SVT 50 joules. Tapos ventricular tachycardia 100 joules. Sir, bakit may naririnig kaming 150 200? Yun kasi walang pulso na. Ito guys, pre-arrest, may mga pulso pa to. Kaya specific tayo sa ating pag-cardiovert. SVT 50 lang. Ventricular tachycardia with pulse, sorry, it should be 100 joules. Okay po? And that's for the pre-arrest setting. Now, let's have the arrest setting na. Guys, pag arrest setting na po, we always perform BLS or the basic life support. 'Di ba? But this time, this will be on the hospital na set up na po. Wala na yung mga naituro sa inyo na, 'di ba, the scene is safe, na up and down, na ayan, then you what? No, you tap the hey hey are you okay? Yung hey hey are you okay? Yes, meron pa 'yon. Pero dapat tawagin mo siya sa pangalan niya. Mrs. Fernandez, are you okay? Mrs. Fernandez, are you all right? Mrs. Fernandez is unresponsive. Guys, do not shout for help. Like, help, please activate the emergency response system and you grab an AED. Then nasa loob ka ng hospital. Hindi ka sure kung safe ang hospital? Tapos bakit ka sisigaw? Pwede ka naman diretso. Code blue to ER bed 1 please. Baka kasi machismis ka na. Baliw na ba to? Nasobraan na to sa BLS Iba po ang BLS intra-hospital. Iba din po ang outside or the pre-hospital setting. Ang ACLS natin, ang BLS natin dito will be intra-hospital. Kaya ano ang nawawala? Yung mga look up and down. Wala na yan, te. Pwera na lang kung nasusunog talaga yung hospital. Diyos ko po, katakot. Ayan. So kung sure ka na safe, okay, diretso ka na, tawagin mo sa pangalan. Mr. Ricardo, are you okay? Mr. Ricardo, are you all right? Ayan, Mr. Ricardo is unresponsive. Code blue to ER bed 1, please. Code blue to ER bed 1. Checking for pulse and breathing. 1,000. Naturo ba sa inyo na sabay-sabay na po ang pag-check ng pulse and breathing? It's simultaneous na based on the AHA 2020 guidelines. So 1,000, 2,000, 3,000, 4,000, 5,000. The patient has no pulse and is not breathing. It's time for me to what? Not to start with my high quality chest compression. All right, nag-start ka na ng high quality chest compression. Sabi ng doktor, 2 minutes up. Let's stop, let's analyze, and let's switch roles. Rhythm on screen. VFib. VTAC without pulse. Guys, VFib, VTAC without pulse on screen. Class 1. Class 2A. Class 2B. Iba-ibang management to. Pag VFib po or ventricular fibrillation or ventricular tachycardia without pulse, meaning nag-arrest na si patient, we need to start with class 1, high quality chest compression. Next, defibrillate the patient to what? No, to 150 to 200 joules. Guys, pag arrest po, automatic 150 or 200 yan. Wala na yung 360, it's obsolete na. Kasi based yan sa monophasic. Biphasic na po ang ginagamit. Even your AEDs are biphasic in nature. And they are ideal. Next, aside from defibrillation po, we have your letter B. There should be no drugs first. Ayan. Alam niyo ba ang kanta ngayon? Kung di rin lang tayo sa huli. Parang nagpaparinig to eh. No? Tapos ang tinuturuan ko from Bicol pa talaga eh. Naalala ko tong song na to. O i-share ko lang ha. Kasi syempre naghiwalay kami no. Ayan, so ayun. Pinilit ko talaga, sabi ko uwi talaga ako. Ako ang nakipaghiwalay na I was heartbroken that time. Ayan, so ayun. Sabi ko talaga, I need to go home na. So from Bicol, kahit lockdown yon, I rented a van. Na? I spent almost 15,000 na just to send me home, send me back na, to Manila. And then from Manila, doon din ako nag-decide na sabi ko, uwi muna ako ng Davao. Na, ayan, kasi lockdown naman eh. No? Amazing lang. Kasi, yeah, pinapili kasi ako, is it between your love life or your family? Sabi ko talaga, pipiliin ko talaga yung family ko. No? Kasi mas kailangan nila ako dito sa Davao. Na, ayan, although yeah, I really enjoyed Bicol so much. Like sobrang nag-enjoy ako. Amazing ang tao sa Bicol. No? Friendly. Hindi ko alam kung nilalandi ako or friendly lang talaga sila. And I love the food. So spicy. Like, grabe. Like kung may hemorrhoids ka, good luck te. Yun yung cause of death mo dyan. Ayan, so we have the VFib, okay, VTAC, negative pulse, no drugs. However, Pag sinabi ni mahal na Doki, na sabi niya, ayan, greater than 2 minutes na po, 2 minutes up. Ayan, sasabihin ng doktor, for a while lang ha, may utusan. Pinagalitan ko na. Kapatid ko pala yung maingay, guys. Hindi pala kapitbahay. The compound kasi kami. May birthday kasi. Birthday pala ng pamangkin ko. Ayan, so greater than 2 minutes po. Ngayon ko lang alam na birthday niya pala. So greater than 2 minutes. So ano sasabihin natin? 2 minutes up, let's stop. Ayan. Sasabihin ni Doc, let's SAS. Anong ibig sabihin ng SAS? Let's stop. Let's analyze. And let's switch roles. Let's stop the compression. Let's analyze the rhythm. And let's switch roles po. Analyze and switch. Stop the compression. Let's analyze the rhythm on screen and let's switch roles. Yun usually ang sasabihin ng doktor, ng team leader. Okay? Ayan, sir, bakit magsa-stop? Kasi para ma-analyze natin ang rhythm on screen. Kasi if you're going to continue with your compression, malamang na maiiba, di ba? Ayan, ma-alter po, no? Yung i-analyze po natin na ECG reading. So again, you stop the compression, let's analyze, and then we're going to switch roles. Now, what if after 2 minutes, sinabi ng doktor, let's stop, analyze, and switch roles? We need to what? No, okay, pagbasa mo sa screen ng VFib, VTAC ulit, without pulse. Guys, if that is VTAC, no? And VFib, without pulse, ano po ang gagawin po natin? So the same pa rin po. We have our class 1. Ayan, class 1. And then we have the class 2A. And then we have the class 2B. For the class 1 po, the same pa rin. Perform high quality chest compression. You're going to defibrillate the patient. Ayan, 150 to 200 joules. And then we're going to give, the drug of choice, now. Okay po ba? Sige, kopyahin nyo muna. Okay, kopyahin nyo muna. So basically, if on screen po ng ating ECG, na let's say monitor po natin, ayan, VFib or ventricular tachycardia, negative pulse, basically class 1 po, it should be your high quality chest compression. You need to begin with high quality chest compression. To be followed by your class 2A, which is your defibrillate, ayan, 150 to 200 joules. Guys, bakit nga 150 to 200? 200 will be the maximum since we are using the biphasic defibrillator. And then lastly, we're going to give the drug of choice. Now, the drug of choice kasi, since kanina, yung first attempt kasi natin, kaya wala siyang drug, kasi your VFib, your VTAC without pulse is a shockable rhythm. Baka ma-okay pa siya ng defibrillation natin. However, hindi kasi siya na-okay upon giving defibrillation of 150 to 200 joules. So therefore, this is the time na we need to give the drug of choice. Guys, on the second run po, you need to give the drug of choice, which is the epinephrine. Your epinephrine will be your 1 milligram, 1:10,000 dilution. You flush it with 20 cc of your plain NSS. Ayan, 20 cc of plain NSS. And then you're going to elevate arms of the patient. Elevate arms for about 10 to 20 seconds po. Did you get me? So we have the epinephrine 1 milligram, 1:10,000 dilution. You flush it with 20 cc of plain NSS and arms elevated for about 10 to 20 seconds. Now, ano bang ibig sabihin ng 1:10,000 dilution? Now, you're going to get a 9 ml of your plain NSS plus your 1 ml of your epinephrine, making it 10 ml. Pagbigay mo ng 10 ml na push, you're going to administer 20 cc just to make sure na papasok talaga siya sa systemic circulation po natin. And ideally kasi, it should be at the left brachial vein kung saan malapit ang heart. Dati kasi, 2015, either left or right po na vein ng arm ng client natin, yung brachial vein. Pero kasi during emergency scenario, during a cardiac arrest, mas maganda po pag nasa left brachial vein. Okay po? Ayan, sige. So we have your what? Now, sir, what if after 2 minutes, ganito ang nangyari? What if, greater than 2 minutes na tayo, 2 minutes up. Sasabihin ng doktor, let's stop the compression. Let's analyze the rhythm on screen and let's switch roles. Now, stop, analyze, and switch roles. Sir, the same pa rin. Doc, the same pa rin. VFib, VTAC, negative pulse. Ano ang gagawin? Okay ni Doc, sasabihin ni Doc, okay, the same pa rin. Now, sorry sa Instagram. Ano ba yun? So we have the class 1. So we have our class 1, we have the class 2A, and then we have the class 2B. Now, for the class 1 po, ayan, you're going to perform high quality chest compression. Yes, you heard me right. Starting today, it should be pronounced as high quality. You need to address that one as your high quality and not CPR alone. Okay po ba? Kasi pag sinabi mong high quality, you tend to follow the principles of high quality chest compression. Okay po? So class 2A, we need to defibrillate the patient now. 150 or to 200 joules po, walang problema. And then sir, we give the drug of choice. Ganito, here is the catch. Nagbigay ka ng epinephrine. And alam nyo ba, every 3 to 5 minutes po, binibigay ang ating epinephrine? Since every 3 to 5 minutes yan, ang sabi ko, 2 minutes up. Meaning may 3 minutes pang gumagana ang epinephrine po natin. Now, here is the catch. Ang sabi kasi ng study, wala pong proven effectivity na dire-diretso ang ang epinephrine mas maganda. Wala. Wala po. Mas maganda pa according to study na ayan, syempre evidence-based approach po tayo. Mas maganda ang epi tapos amiodarone. Epi tapos amiodarone. Epi tapos amiodarone. Kesa sa epi tapos pronounce the call out that time of death patient. Mas maganda ang epi-amio, epi-amiodarone, and then call out the time of death. See? Guys, you heard me right? There is actually no maximum dose sa ating epinephrine. Wala pong maximum dose. Bakit mo ipagkakait po ang 75 pesos sa kaligayahan ng isang pamilya na mare-revive mo kasi ang kanyang father or let's say mother or let's say ang kanyang siblings, their grandmothers, na? Ayan, so wag nang ipagdamot. And ethically po, there's no maximum dosage sa epinephrine. May mga doctors na nagbibigay up to 10 epis. No? Yung tipong hindi sila susuko. Kasi alam nila na may kaligayahan pang maidudulot to sa pamilyang posibleng maiwan or posibleng hindi maiiwan. Na? So, ayun po. So we have the drug of choice. Guys, bawal kasi ang epi dire-diretso. So we have another drug of choice here. After, 2 minutes, we have the amiodarone. Ayan, aside sa amiodarone po, pwede rin po ang isa, known as the lidocaine. Dati tinanggal nila si lidocaine, ngayon binalik nila ulit, 2020 guidelines. Amiodarone, guys. Ayan, the dose for amiodarone here, first dose will be 300 milligrams. First dose. Second dose will be 150 milligram. Still, you flush it with 20 cc of your plain NSS. And still, you're going to elevate the arms of the patient. Sir, why do I need to elevate the arms of the patient? Just to make sure na papasok po ang mga gamot po natin. Yun yung purpose kung bakit siya elevate. Kasi nga, di ba, nag-arrest ang patient. So malamang walang pulso to. By flow of gravity, papasok po yan sa systemic, sa heart, and then yes, no, pwedeng papasok na sa systemic circulation. Next, we have the word lidocaine. Now, when we say lidocaine, pag sa states, they pronounce this one as the lidocaine. Yan. Ayan, lidocaine. Ayan, what's the first dose ba of our lidocaine? The first dose will be the 1 to 1.5 milligram per kilogram, with its second dose of 0.5 to 0.75. Ayan, milligram, ayan, per kilogram. So meaning to say, ganito ang pagkakabigay. No drugs first, and then next will be epi. Next drug will be amiodarone first dose or lidocaine first dose. Next will be epinephrine second dose. Next will be the second dose of amiodarone or the second dose of lidocaine. So ganun po magbigay ng mga drugs na to or medication. All right. Now, next topic, we have the asystole or the PA. Guys, nag-discuss ko ng asystole kanina, tama? Si PA, ganito. Alam niyo ba na ang PA po, meron siyang mga reversible causes. So we have the reversible causes, okay, of your PA. When I say reversible, doctors kasi will going to ask you, na, they will ask you like, oh, ano kayang possible reason kung bakit po nagkaroon ng tinatawag na PA? Ayan, so syempre si nurse dapat alam ang mga possible reversible causes. So we have the H's and T's. Pag sinabi kong H's, okay, and T's, letter H, very common po si hypovolemia. Next, we have the hypothermia. Next, we have the hydrogen ions. Sorry. It should be ions. Next, we have your letter H po. We have the hypokalemia. And then we have the hyperkalemia, guys. So we have the hypovolemia, hypothermia, hydrogen ions, hypokalemia, and then we have the hyperkalemia. Now, for the T's naman po natin, ano yung mga example ng T's? Number 1, we have the tamponade. Tamponade or cardiac tamponade. Diba? Mga ano natin, mga heart failure. Next, we have your the tension pneumothorax. Tension pneumothorax. Aside from tension pneumothorax, we have your the toxins. Next, we have your the thrombosis. Thrombosis. Ang thrombosis, pwedeng cardiac thrombosis or cardio. Next, we have the pulmonary thrombosis. Paano i-apply yan, sir? Ganito. Kunwari nag-PA ang patient, tapos sabi ng doktor, what are the possible reasons? Mr. Adlawan, ano kaya ang possible reasons kung bakit nagkaroon ng PA si patient? So ikaw na nurse, sabihin mo, Doc, kasi ang patient kanina, arriving at the emergency department with signs of dehydration, boom, hypovolemia. Or let's say, Doc, ang patient kasi, grabe kasi ang diarrhea ng client. Okay, boom. Ayan, nag-hypokalemia ang patient. Or let's say, grabe ang dehydration. Okay, na-hypothermia ang client. Ayan, may mga shock na, may mga symptoms of shock na din. Ayan, or let's say, Doc, ano bang nurse, ano ba nangyari? Doc, nagkaroon kasi ito ng ng motor vehicular accident. So may chest trauma ang patient. Okay. Tension, pneumothorax. May heart problem kasi to, Doc. Okay, sige, may heart failure. Doc, si patient si Doc nag-suicide. Baka may in-ingest yan ng mga harmful chemicals, mga toxins, ganon. Ayan, nag-suicide. Pero guys, kailan ba masarap suicide? Number 1, pag nag-post ka sa Facebook tapos walang nag-like. Yan, masarap mag-suicide. Tapos pag nag-change ka ng primary pic sa Facebook, tapos walang nag-like, Diyos ko po. Tapos after 4 hours may nag-like na. Mama at papa mo pa talaga nag-like, ha. Supportive ang parents. Ako sa inyo, delete nyo na lang yung post nyo. But I find it really toxic kasi ang Facebook ngayon eh. Facebook Messenger is okay, but the Facebook itself, sobrang toxic, ang daming nega. Ako honestly, kahit taga Davao ako, parang magti-TikTok agad terererek, hindi po ako solid Duterte. Yeah. Ako taga Davao ako pero I'm not a fan anymore. I don't know why. Siguro it just nag-fade lang talaga siya. Andito pa si Dr. Isip. Hi, hello Doc Isip. Good morning, Doc.
Morning. Pasensya.
Good morning po. Kamusta ka, Doc?
Okay, duty ako eh. Toxic.
Ay, okay lang, Doc.
Long time, ano?
Naka-record pala so pwede niyo pong hingin.
Okay.
Yes, Doc Isip. Na-miss ko kayo. Kasi naghiwalay na kami ng consultant.
Okay. Tatanong ko na nga sana eh, kumusta na kayo eh. Ganon. Okay.
Wala na yun. Kinalimutan ko na pass.
Iyo. Okay. Joke. Oo nga.
Ano nangyari?
Nawala si sir. Nawala.
What happened to him? Where did he go?
Guys, nawala yung net ko. Hello, Doc Elmo. Ay, Doc. Doc, parang parang nagalit tuloy yung internet ko. Parang bigla akong dinisconnect. Ayan. Sorry guys ha. Live po tayo ngayon. Kaya biglang nawala ang net. Grabe. Wait lang. Sige po. Kinoconnect ko na yung isang gadget ko for a while. Ayan. Can you hear me ba? Or parang halos ata. Ayun. Yes po. Hindi na lang muna ako mag-video po for a while. Ito yung problem natin pag pag mga online talaga nawawala ang net. For a while lang po. Ayun. All right. Ma'am Wipam, pa-confirm na lang nung isa. Ayun, admit. Okay, so for the asystole, okay, and you're the PA guys. Ayan, ang basic ang natin ngayon, of course protocol po natin is that pag nakita po natin na asystole siya, ayan, and then we have the PA or the pulseless electrical activity, is that we have our class 1. Now for the class 1 naman po, and then we have the class 2A, and then we have the class 2B. Doc Elmo, if mapunta kayo ng Davao ha, just tell me, bigyan kita ng ng suha. Ayan, I'll visit you sa hotel niyo kung saan man kayo, na. Ayan, other doctors kasi na bibisita po ng Davao. Tas ayun, yung mga naku-close ko ng mga doctors diyan. Ayan, bigyan ko kayo ng ng mga suha po. Ng mga pomelo. Ayan, for class 1 po, we always require na dapat may high quality chest compression po dapat kay patient. Now, aside from the high quality chest compression, guys, take note, this is your asystole. Tama po ba? If this is your asystole or PA or the pulseless electrical activity, then there should be no defibrillation. Hindi po tayo mag-defibrillate. And then for class 2B po natin, now this is the time na magbibigay po tayo ng drug of choice. Now if that's your asystole or PA, ayan, dalawa ang drug of choice natin. Pwede nyo silang, okay, let's say, tapos ka na magbigay ng epi, okay, sige. Next will be the amiodarone. The same lang din kanina sa ating VFib at saka sa ating BTAC. So the drug of choice here, we have the epi, 1 milligram, 1:10,000, okay, dilution. You flush it with 20 cc of your plain NSS, and then arms elevated. Okay, so we have the arms, okay, elevated dapat for about 10 to 20 seconds lamang po. So again, sir, ano yung protocol natin? Okay, for the asystole, you provide high quality chest compression, There should be no defibrillation. The drug of choice will be epinephrine, 1 milligram, 1 is to 10,000. Ano nga ibig sabihin ng 1 is to 10,000? 9 ml of your plain NSS plus your 1 ml of your epinephrine. And then ipupush natin kay client. And then after pushing it at the left brachial vein, ayan, you give 20 cc of plain, ayan, NSS po. Okay? Ayan. At this point in time, itry po natin silang, ayan, no? Let's say, i-discuss na natin si pre, si arrest, at saka si post-arrest setting. Kasi tapos na po tayo sa ating ECG eh. Ayan. Doc Elmo, the same naman din ang flow. It's just that may mga nabago lang based on the COVID na protocols. Ayan. And then I'll be giving you the ano po, yung mga let's say pictures na kung ano ipa-follow natin based on the BLS with COVID, na ACLS with COVID. Isi-send ko na ayan sa inyong mga ano po, sa email niyo din. Ayan, sige. So let's discuss the pre. We have the arrest setting. And then we have the post-arrest setting na po. Magfo-focus muna ako guys sa kay pre-arrest setting. Now, on the pre-arrest setting, meaning kausap mo pa si patient, we usually follow po a mnemonic for this one, known as the vomit na mnemonic. Bakit vomit? Sunod-sunod kasi ito eh. Number 1, you need to visualize the client. Ayan, kung ano ba ang nangyari sa client mo. Ano ba ang mga physical symptoms ng client natin? Next, you verbalize. Magpakilala ka sa client, whether doctor or a nurse. And then you check the vital signs of the patient. Lalo na yung heart rate ni patient. The BP, yes. The RR, yes. And of course, na the O2 sat of the patient. Guys, what's the normal O2 sat? It's 95 to 100% ang normal O2 sat ng patient po natin. Now, if that's the normal O2 sat ng patient, alam niyo ba, pag less than 94 na po ang O2 sat ni patient, this is the time na magbibigay tayo ng O2 therapy kay patient. Now, sir, ano ba yung mga O2 therapy na binibigay? Number 1, we have the nasal cannula. Next, we have the simple face mask. Next, we have the non-rebreather mask. Nasal cannula, guys. Ayan, nag-aaway yung mga pusa ko dito. Ayan, nasal cannula. Ayan, 2 to 4 liters per minute. Next, for the simple face mask, we have at 6 to 10 liters per minute. Then non-rebreather mask po at 11 to 15 liters per minute. Again, you follow the protocols based on American Heart Association. Letter M, you're going to put the patient on a monitor. Siyempre yung ECG natin, 12 leads. And then we have the letter I for IV or IO, intravenous or intraosseous, pwede. Intravenous, guys, via vein rather. Pag intraosseous, via the bones of our patient. Lahat ng mga drugs, let's say yung mga emergency drugs po natin, kung dadaloy yan sa vein, malamang dadaloy din yan kaysa what? Nasa bone po natin. And then next, we have the treatment. Treatment ng ano yon? Sinus bradycardia. Tapos na tayo dyan. And then we have the SVT. And then we have the VTAC. Tapos with pulse. I-apply ko. You listen carefully. A 75-year-old female patient arriving at the emergency department. Ayan, whose name is Mrs. Ricardo. Mrs. Ricardo is a cold, clammy, diaphoretic patient on ER bed 1. Approach her patient now. Visualize. Tapos na. Verbalize. Good morning, Mrs. Ricardo. I am Mark Adlawan, your most responsible nurse. How are you feeling today? Mr. Adlawan, I feel like I'm dying. Okay, Mrs. Ricardo, you seem upset. But before that, let me check your vital signs. Heart rate, BP, RR, O2 sat. Mrs. Ricardo, your O2 sat is below 94%. So I'm going to hook you to a nasal cannula. Okay, regulated at 2 to 4 liters per minute. Attaching the patient to the cardiac monitor. Inserting IV at the left brachial vein. Okay, left brachial vein of the patient is now patent and ready for infusion. Now, biglang nahimatay, biglang nawala ng consciousness si Mrs. Ricardo. So we are now on the arrest setting. Sa arrest setting, guys, you perform BLS. Ayan, you perform BLS po. That's the BLS survey. Tama? Ano nga yung BLS survey natin, guys? Ano nga yung mga principles of high quality chest compression? The mnemonic, pucha na mnemonic. Letter A stands for push hard and fast of a rate of 100 to 120 compressions per minute. Next, unnecessary interruptions must be minimized. Must be minimized po. To not more than 10 seconds. Next, compression deftness must be adequate. Deftness must be adequate. Bakit ganito? Pag nagtuturo ako ng mga taga Bicol, as in like yung Pasko talaga, parang naaalala ko tuloy. parang na-flashback agad, na like in an instant. So yeah, compression deftness must be adequate. Although yes, good memories naman talaga ang tinetreasure ko eh. Yung mga bad memories, I don't treasure them. Now, para yung mga bad memories ko, yung mga nabagyo ako sa Bicol. Grabe yung mga bagyo natin dyan, no? Ayan, letter H has an obvious chest recoil. Ayan, chest recoil. Pag sinabi kong obvious chest recoil po, there should be the upward and the downward movement of the chest of the patient. And lastly, you need to avoid excessive ventilation. Guys, listen. Bakit nga kailangan i-avoid ang excessive ventilation? Because excessive ventilation, it causes two things po. Increased intrathoracic pressure and increase intra-abdominal. And increase intra-abdominal pressure po. Okay po ba? So we have the mnemonic pucha. Push hard and fast. Unnecessary interruption must be minimized. Ayan, to not more than 10 seconds. And then has an obvious chest recoil. Avoid excessive ventilation. Ito yung focus natin sa arrest ha. Yan lang at wala ng iba. Now, let's proceed na po sa ating last topic. And that's the post-arrest setting. Guys, this will be my last topic. The post-arrest na po. Now, with your post-arrest setting, para masabi natin post-arrest, after an arrest kasi yan. If that is after an arrest setting, ayan, what if, guys, if ever kung bigla akong mawawala, kasi nag-data ako bigla eh. Ewan ko pa nangyari sa wifi ko. Pag bigla akong nawala, sige lang, babalik ako bigla. Post-arrest, kasi sabi na ng laptop ko, unstable na yung internet connection ko. Now, post-arrest setting, so you need to what? Determine, ayan, you determine ROSC. Alam niyo yung ibig sabihin ng ROSC? This means return, ayan, of spontaneous circulation. If that's the return of spontaneous circulation, ano yung mga parameters natin? Number 1, pag may pulse na ang patient natin. Pag may pulso si patient. Next, pag may RR na si patient. Next, pag may BP na ang patient mo. At pag may PETCO value, PET CO2 na po si patient natin, 30 to 45. Okay, PET CO2. Now, ayan, in determining the return of spontaneous circulation, meaning okay na si patient, na-revive na natin. However, kasi, with your post po, no, ayan, let's say post-cardiac arrest setting, may focus tayo na airway, breathing, circulation, and then we have the disability. Tapos, may sign of the cross tayo dito. Okay po? Now, airway breathing. Pag alam na po natin na na-revive na ang client, okay, check for pulse. However, ang scenario mo is that the patient has pulse rate, pero negative RR. Alam nyo kung anong gagawin dito? You perform rescue breathing. Pero pag ganito ang nangyari, GCS is less than 8, and then ang kanyang O2 sat is less than 84%. Guys, iba na po ang gagawin nyo dyan. You intubate the patient. Pero may mga doctors po na hindi nila hihintayin na mag 84% pa. Yung iba, 89, tapos pangit na ang mga ano ni patient, nag-intubate na. So depende talaga yan sa ating mga mahal na mga doctors kung kailan ang best time sa kanila. But AHA recommends na if GCS less than 8, O2 SAT less than 84, then you intubate the patient. Okay po? Next, circulation as our next topic. In the circulation, guys, what if the patient presented hypotension? Let's say hypotensive ang patient mo kasi kagagaling lang ng resuscitation eh. Although na-revive mo si patient pero hypotensive. Alam niyo ba may gagawin po tayo if hypotensive si client, guys? Ayan, first thing to do. Number 1, you need to check, okay, for breath sounds. You check for breath sounds. Ayan, ganito. If positive daw, ang tinatawag na crackles or ralls, alam niyo ba ang crackles or ralls? Okay, this means what? A fluid-filled lung. If that is a fluid-filled lung, then you are not allowed to give IV bolus. Na? Instead, you can give your drugs here. Management will be give drugs such as D, E, N. Bakit D, E, N? Dopamine at 10 microgram per kilogram per minute. Next, we have the epi, and then we have the norepinephrine of 2 to 10 microgram per minute. Walang per kilogram ha pag epinephrine. Si dopa lang ang may per kilogram per minute. Isulat natin ng maayos. We have the 10 microgram per kilogram per minute po. Okay po ba? So we have the dopamine. Unahin mo muna si dopamine. If ineffective si dopamine, okay. Na pataasin ang BP by giving epi. Tapos pag ayaw pa rin, okay, sige, give your norepi. So meaning to say, ang ginagamit sa hospital, pampataas ng BP, dopamine talaga muna. If dopamine, 10 microgram per kilogram per minute ineffective, okay, give your epinephrine. Pag wala pa rin, okay, sige, give your norepinephrine. Okay po? Now, what if, ganito, pag auscultate mo, negative crackles naman eh. So negative ralls. Crackles or ralls, they're just the same. They are the popping sound na bumubukal kasi fluid-filled ang lung mo. Now, pag negative crackles po, this is the time na magbibigay po tayo ng 1 to 2 liters. Ayan, IV bolus. 1 to 2 liters IV bolus of your plain NSS yan. Guys, pag sinabi kong bolus, ayan, fast drip po tayo ha, ng 1 to 2 liters of your plain NSS. Okay po ba? So again, you check for breath sounds if hypotensive ang patient. We need to know whether may crackles or ralls or walang crackles or ralls. Pag may crackles, bawal kang magbigay ng IV bolus, mas lalong malulunod ang patient mo. So you can give your dopamine or epi or norepi. Pero pag negative crackles naman, sige, mag-fast drip tayo para tumaas ang BP. Fluid therapy tayo or fluid resuscitation. 1 to 2 liters of IV bolus of your plain NSS. Now, aside from circulation, we have the disability. Sir, paano ba ang disability? Siyempre, sasabihan mo si patient, ayan, Mrs. Fernandez, can you squeeze my hand? Pag may response po, okay ang kanyang GCS. Na? Okay ang kanyang GCS. Pero pag no response, Mrs. Fernandez, ayan, sa Bisaya kasi kumuta ang ako ang kamot. Na? Ayan. Or you what? You squeeze na, you grasp na my hand. Na? Ayan. So pag may strong gripping tayo, okay, kung wala, pangit, no? Ayan, so malamang sa malamang may gagawin tayo. Guys, ganito. Sa disability kasi, lalo na pag GCS, okay, ayan, let's say GCS 3, kasi no response eh. The result is 3. So we need to have the management of what we call as the targeted temperature, ayan, temp management or the TTM. Guys, pag sinabi po nating targeted, ayan, temperature, okay, ayan, targeted temperature management, you're going to cool down, di ba? The temperature of the patient. Why? This is to decrease oxygen demand. To decrease oxygen demand from the brain. Meaning para hindi po ma-overuse ang brain natin, para ma-relax ang brain, palamigin mo muna ang patient. Kasi this is to prevent the occurrence of stroke. Yun yung purpose niya talaga. Now, to decrease the occurrence of stroke, and therefore we need to have the targeted temperature management. Now, question. Sir, ano ba ang gagawin natin? Siyempre, you're going to maintain a core body temperature of 32 to 36 degrees Celsius. Ayan, using cold saline. Cold down na plain NSS at 4 degrees Celsius for at least 24 hours po. Ulitin ko ha. The purpose of your targeted temperature management is to prevent the occurrence of stroke. This is to decrease oxygen demand from the brain, maintaining a core body temperature of 32 to 36 degrees Celsius using a cold saline for about 4 degrees Celsius. Okay po? Ayan. For at least 24 hours, guys. Yan yon, na? Okay. Pasensya na, nawawala ako. Ito, internet. Ayan. Okay, we need to have the sign of the cross. Listen carefully ha. Bakit daw NGT? 'Di ba kasi before may transport ang patient natin sa from ER to ICU, kailangan natubuhan na yan. Or let's say via NGT. Yeah, the NGT. No? Tube. Kasi yung term natin ng mga tubo, common talaga siya sa ET. No? Although tube naman din kasi ito kasi NGT eh. So nasogastric tube. So yeah. Ano bang purpose nito? This is to gavage. Diba pag sinabi natin gavage, you give, you feed. Letter G o gavage. Tapos pag lavage, lavas, you irrigate. Ito, you feed the client. Ito naman, this is to irrigate. Lalo na, kaya pala siya ng PA kasi may poisoning pala to. So toxins, diba? So we need to lavage. Next, we have the Foley-cath. So catheterization, Foley catheter. Next, we have the portable X-ray. Guys, question, bakit kailangan may portable X-ray dito? Anyone? Anyone from the group? Bakit kaya kailangan may portable X-ray? Plain and simple. Kanina pa kasi tayo nagko-compress kay client. Kaya pala nag-tension yung thorax kasi may bali-baling ribs ang patient natin. So to confirm whether may rib fracture ang patient, we need to have a portable X-ray. And this is to know also the exact location of our endotracheal tube kasi nag-intubate tayo. Next, we have the 12-lead ECG. Ayan, why? Because I need to know the complete picture ng heart po ng patient po natin. And then lastly, para malaman mo kung hypervolemic or hypovolemic ang patient, there should be your central line access. 'Di ba? Yung natin, yung central venous, 'di ba yung CVP mo? The central venous pressure natin monitoring. Kasi if increase ang CVP, that means hypervolemia. Grabe ang fluid sa katawan. Ayan, pag less than naman po, ayan, hypo, ayan, volemic naman po ang patient po natin. So ulitin ko ha, before po natin guys na i-refer ang patient or i-endorse ang patient natin na sa ating ICU, we need to have the sign of the cross first. NGT, that is to feed the client. Pwedeng feeding, pwedeng irrigation. Next, Foley catheter, 'di ba? Ayan, because we need to know the urine output of the patient. Because a good urine output, that means a good cardiac output then. They are directly proportional to one another. Next, we have your portable X-ray because I need to know whether may rib fracture ba ang patient. or baka nagkaroon na yan ng tension pneumothorax, no? Kasi kanina pa tayong nagko-compress. And then we have the 12 lead, okay, ECG kay patient because I want to know the complete picture ng heart ng patient. And then lastly, we need to have the central line, okay, access po. And that is for CVP monitoring. If increase CVP, hypervolemic patient. Pag decrease ang CVP, that means hypovolemic, okay, patient po. And then this is the time, okay, for you to endorse now na the patient to the intensivist. Endorse, okay, to an intensivist. Ito yung mga tao guys sa loob ng okay, ICU po. All right, that's the end of our okay, lecture na po. Tapos na tayo from arrest and then we have the post-arrest. Usually guys, sa actual na training talaga namin, pag hapon na po will be the mega code. Kaso we cannot, okay, we cannot, handle din kasi the mega code via online. Wala kasing ganun eh. So it's purely lecture. So if ever man, kung babalik na po, no, let's say ang ating training, let's say the face-to-face, most probably i-invite talaga kung sino yung mga students na nasa online. Okay po ba? Ayan, sige. So before I'll end na my discussion guys, okay lang bang makita ko yung mga mukha po natin? Para at least na, magpipicture-picture tayo. Doc Elmo, naka-record naman na sila Doc. So if you have time, pwede mo namang pakinggan yun Doc. Na.
Hello po.
Hello Doc.
Ay, napaka-busy ng aming OPD.
Ayan, Doc.
Okay.
Ayan, magpipicture-picture na tayo ha. Magsi-screenshot na tayo. O, sana yung mga ano natin. O, ayan.
Wait lang sir, palit ako na.
Sige. Tapos para tapos isi-send ko sa WePump. Ay, wait lang. Magpalit-palit lang daw muna si Doc. Si Doc Melchor. Ayun. So guys, ganito. You can message me. Ilalagay ko lang yung yung email ko. And then right after this, bibigyan ko kayo ng manual din na based sa AHA no, at yahoo.com. Okay po? So it's jedx439 at yahoo.com. Tapos isi-send ko sa inyo ang manual ng American Heart. BLS and ACLS nila. Kaso bawal i-share sa iba. Sa inyo lang 'yon. Baka mapagalitan kasi ako eh. As in like bawal na bawal 'yan. Okay po? Sige. Kamukha pala ni Doc Melchor yung Hindi yung ex ko ha, yung kalandian ko lang sa sa Legazpi na nasa UK na ngayon, Chos. Buti pa yung mga kalandian ko guys, nasa UK na, nasa Amerika, mga ganun. Ako kasi siguro love ko talaga ang Pilipinas eh, no? Sige, picture. So, pwede nyo ako i-message today ha, para isi-send ko na ASAP din, na yung mga manuals po. Although may manuals na po ang WePump, na pero kung gusto niyo talaga ng actual na American Heart, pwede kong ibigay sa inyo yan for free. Kasi pag sa AHA po, binibili po ng mga 5,000, 3,500, ganon. Na? I love piracy kasi eh. Just.
Sir, kindly repeat po.
Yes po. Doc?
The address po. The link.
Ito po, Doc. Ito po, Doc. Nasa screen. Ay, yung JEDX.
No.
Ito pala si Hello, Doc.
Paano ba yun? Sorry Hindi ko nakikita po. Saan po?
Sige, Doc. I-dictate ko na lang po, Doc. JED X 4339 at yahoo.com.
Yahoo. Okay, thank you.
Yes po, Doc. Ayan, so picture na tayo, guys ha. So again, before tayo mag-iwahiwalay, no? Thank you for listening po. And then I really believe na once you stop learning, you stop growing, no? So I hope from time to time, no, we need to update ourselves din. Lalo na ngayon sa BLS, gumagamit na po ng HEPA filter, no? And isasama ko din po sa ating email yung mga yung mga algorithms based on the COVID pandemic. Kasi sa COVID ngayon, guys, they limit personnel talaga. Nililimit ng personnel. And then, gumagamit na sila ng Lucas device. If you're familiar kay Lucas, ito sa States kasi to eh. Ayan, i-sum up ko lang sila. Ito na po si Lucas. Saan ba si Lucas? Ayun, this is the Lucas device.
On side. Happy with position? Yes. Okay, turn Lucas on. Okay. 2. 30 to 2.
Stay clear of patient. Analyzing.
Okay, Emma and Zoe, you get changed to PPE gear. I'm Caroline, I'm going to be team leader.
I'm over, I'm the anesthetist.
Lovely. And when you have a free...
Okay, so yan na po si Lucas device na ginagamit po natin ngayon. And yeah, sa States, ginagamit nila. Sa UK, ginagamit nila. Sa Philippines, well, tayo pa rin po ang tayo mismo eh, no? Ayan, tao talaga ang ginagamit po na pang-compress po. Ayan, yes, magte-take pa po sila ng exam. Ayan, para ano po, no, para maibigay talaga sa inyo ang certificate, okay? Cards po. So, by the way, guys, no, again, once you stop learning, you stop growing. Thank you for listening. Ayan, and right after this, mag-exam kayo. Pero before that, okay lang ba mag-picture-picture tayo? Sige, screenshot tayo ha. Sige, 1, 2, 3, smile. Isa pa, V sign guys, para virgin. V. V sign, 1, 2, 3, smile. Ayan, thank you sa ating mga doctors and sa ating lovely nurses, no? And sa, of course, ating medtech. Sana yung medtech natin, si Sir Paul. Ayan, thank you. Mag-ingat po ang lahat. And then magpabakuna na dapat. Okay? Ayan. Thank you for listening. Bye. Just check your chat na lang. Nakalagay na po ang ACLS natin na exam. Thank you po.
Okay, sir. Thank you.
Thank you so much.